Hello, my dear lovely friends. Very good evening to all. क्या हाल चाल? सब ठीक ठाक? All well? Adi, very good evening to all. So, how is the life going on? सब बढ़िया चल रहा है? So I'm very sure you all are following your schedule, having good strategy, utilizing each and every second of your time and busy with your preparations. So I'm very sure. So Mohammed, Manish, Jishan, very good evening to all. So yes, today is what date? 23rd of June. So we are almost 32 days from our examination date. And I'm very sure that by this time, you all had marked this date in your calendar. And this date is, I'm very sure, it is not less than your birthday date or your marriage date. Okay, so this is a very, very important date. We all are waiting for this. 32 days are left for this. And our main goal is to have best performance on this day and to clear our FMGE July 2025 examination. Now in this journey, many people are supporting you. We faculties are giving you the best content to clear the exam. Along with the faculty, you are having financial support and moral support of your parents, as well as motivation from all your friends, relatives, colleagues. लेकिन जैसे कहते हैं ना कि कितनी भी न्यूट्रिटिव डाइट एक बच्चे के मुंह में आप डाल दो, लेकिन जब तक वो बच्चा उसको च्यू करके स्वेलो नहीं करेगा, उसका कोई फायदा नहीं है. So as we know that how much of the nutritive diet you give to a baby, you put in her or his mouth until unless he is going to swallow. After chewing that content, it will not be beneficial. The same thing is, whatever the support you are getting from all the corners, until unless you are not utilizing this, it will not be of any advantages. So you are the only person who can change the scenario, who can change the result. So at this moment, just promise to yourself that yes, I definitely want to change my life by having the best performance in the upcoming exam, by clearing this FMGE exam. So I will be giving my best, more than 100% to clear this exam. Great. So we will be discussing today a subject that is preventive and social medicine, or we now call as community medicine, in the form of 25 important questions. Now here we are not only discussing the 25 questions, maybe more than 100 questions, covering more than 25 high-yield topics. And very importantly, what we will be doing here is, we will be learning that how to read a question, how to approach a question, how to identify keywords, join those dots, coming to a correct answer in the given time frame. That is very important, because we are being given 1 minute time for each question. So keeping in mind of the time frame, because some of the questions may be requiring more than 1 minute, maybe the numerical part, although some of the numerical part we'll be discussing here, but I'll be taking a separate YouTube live session for especially numericals. So we will be saving time from direct answer questions to give some more extra time for our numericals. So we should be learning a trick that how to solve a question in a given time frame. Simultaneously, we should be getting correct answer. That is very, very important. And यहाँ पे ध्यान रखना बेटा, this exam is not a fastest finger first exam. Now here we are supposed to give the correct answer, maybe taking 30 seconds, 40 seconds, 45 seconds, 50 seconds. ये नहीं है कि आपने अगर 10 सेकंड में आंसर कर दिया तो you will be a winner. No, you should be taking good time, but your answer should be correct. Okay, so this should be our main motto for this session, that we will be learning how to avoid silly mistakes and coming to a correct answer, because we know that this subject is having high weightage in our exam. Now, as per the national board, 30 questions are supposed to be from this subject, but we had seen in the past exams around 35 to 40 questions are asked from this subject. So really this is a game changer. So we should be able to apply our concepts clearly in the given question. So I think by this time we all are ready. So just take a deep breath, settle down. We will be starting our journey of 25 important questions. Now here again I say, take your time, read the question carefully before jumping for your answer. Starting our journey of 25 most important questions, and as I say, read the question carefully before jumping to answer your question. And here comes our first question. As per survey of 10 lakh population, in year 2024 in Madhya Pradesh, the total birth reported are 55,000 and stillbirth are 5,000. During above birth, maternal deaths are as follow. Eclampsia 5, road accident 10, rupture uterus 10, PPH 20, ectopic pregnancy 5. Calculate maternal mortality ratio. Calculate maternal mortality ratio. Now here, if this type of the question is asked, first of all, you have to see what they are trying to ask from us. They are trying to ask is calculate the maternal mortality ratio. So first of all, think definition in your mind. So what is the maternal mortality ratio definition is? It is number of maternal deaths. It is number of maternal deaths per 1 lakh live births. So if you write in a numerical form, it is divided by the total live births. It is divided by total live births multiplied into 1 lakh. So this is your first step. You should be just knowing the formula for maternal mortality ratio. Now you had started answering the question, and yes, you are absolutely right. But we should be understanding that how we had reached to this correct answer. Now the second is, what is maternal death? This is the second point we should be learning. Maternal death means any death of a lady during pregnancy, during delivery, or the first 42 days or 6 weeks after the delivery due to any cause which is directly related to the pregnancy, or it is aggravated by the pregnancy, but it is not due to the accidental causes. So they have given us the deaths. Eclampsia, is it related to pregnancy? Yes. Then road accidents, is it related to pregnancy? No. So we are not supposed to include this road accidental deaths. Rupture uterus? Yes. PPH 20? Yes. Ectopic 5? Yes. So how many are the maternal deaths? 5, 5, 10, then 30 and 40. So here is your 40 is the maternal death. Okay. Now here, what is the next catch? The next catch is that how many other live births they are talking about. The live births is, they had given us a total birth is 55,000 and stillbirth are 5,000. So we have to deduct this stillbirth. So how many will be your total live births? It will be 50,000. And multiplying factor is your 1 lakh. So answer will be 80. So those who are answering the correct for this question, just give a big clap for them. But यहाँ पे I want your attention for next 2 minutes to understand where you can make the mistakes. That is very, very important to understand where you can make the mistake. Okay. So just try to understand that where you can make your mistake. So mistake number one. What is your mistake number one? That if you are counting this 10 deaths as a road accident also in your maternal death, then what will be your answer? The total maternal death, then you will be counting as 50, and if it is divided by 50,000 into 1 lakh, your answer will be 100. That is your first mistake, okay? Second mistake, what you can do, that here, that if you are counting this 55,000 as a live birth, because here they had given you the total birth and you have to deduct the stillbirth. But if you are considering this as a live birth, so if you are considering maternal death as 50, this is your one mistake. And if you are taking in the denominator as 55,000, then your answer will be coming as 90. So this will be your second mistake. Now the third mistake what you can make is that even if you are correctingly calculating this maternal death, but if in the denominator you are not considering as live birth, you are taking as 55,000 into 1 lakh, your answer will be coming as 73. This is again your third mistake. Now the fourth mistake what you can go with this is that here they had given you the total population as 10 lakh. If you consider this 10 lakh in your denominator in place of your live births, so what can be your next mistake? If you are considering 40 as your maternal death, but if you take in the denominator the total population multiplied into 1 lakh, then your answer will be 4. This is again your fourth mistake. The fifth mistake what you can make is, if you consider the maternal death as 50 divided by the 10 lakh into 1 lakh, your answer will be 5. So these are the different mistakes you can make, and the beauty of this question is that all may be given in your choices. So examiner is ready to trap you. वो शिकारी की तरह से आपको पकड़ने के लिए तैयार खड़ा है कि कब ये मुर्गा फंसेगा और मैं जाके घर में कीमा बनाऊंगा और खाऊंगा, पर लेकिन हमें उसमें पकड़ में नहीं आना है उसके, ठीक है? वी आर सपोज टू प्रोटेक्ट अवरसेल्फ from trap which is given by examiner, and how we can protect ourselves is if we know the concept that what is MMR, what is its formula, then we can go with this, okay? Now coming to few more points which are very commonly asked from this high yield topic as maternal mortality ratio, that straightforward, what is the definition of this MMR? It is defined as number of the maternal death. It is per 1 lakh live births. Now, if they ask is maternal mortality rate, if they simply mention as MMR, consider this as maternal mortality ratio. But if they ask as rate, maternal mortality rate, it is defined as maternal death per 1 lakh reproductive female. Per 1 lakh reproductive female, and which female are called as reproductive? The age group is between 15 to 49 years. Then the next point is that what periods are included in the calculation of this is, it is maternal death right from the conception till end of the puerperium, including antenatal, natal and the postnatal. The next question is, which is the most dangerous period for the maternal death? The most dangerous period is your postnatal period. Postnatal period is your most dangerous period. Then what are the causes of MMR? The most common direct cause is, it is hemorrhage. And out of this hemorrhage, the most common is postpartum hemorrhage. And what is the most common indirect cause? Most common indirect cause is underlying anemia. So this is the most common cause of MMR, the direct cause and indirect cause. Now, if we have to make policies to prevent MMR, usually we should be knowing the cause, and cause is known by autopsy. But actually what happens, the maximum deaths are happening in the periphery because deliveries are taking place in periphery, and by the time the team reaches to periphery, cremation has already been done, or the relatives, they refuse to go for autopsy. So now what we had tried to make a policy to get the cause of the death is by verbal autopsy, and it is what is called as, rhyme method. It is called as rhyme method of the verbal autopsy to find cause of death. Now, what is current value of MMR of India? Recently, the report of SRS survey May 2025 released, and as per that, the latest update is that current value of MMR of India is 93. Beta, current value is 93. Okay, it is earlier it was 97, but now it is updated as 93. And those who are writing as 70, these are the goals. So goal of MMR as per SDG, again very commonly asked question is that we have to bring down the MMR to less than 70 by 2030. Remember this point. Then, as per the government of India is, we have to bring down the MMR to up to 100. They had not revised yet, but this was by 2020, and in 2025 we had brought this MMR to 93. So this is all about our this first topic of maternal mortality ratio unrelated questions. Now coming to our second question is, in a statistical survey of pregnant women in a city, it was noted that 50 babies died between 32 to 36 weeks of intrauterine life, and out of reported 10,000 live births, 30 asphyxiated babies, they died in NICU between 2nd to 5th day of life. 20 more died between 2nd to 3rd week of age. Calculate perinatal mortality rate. Calculate perinatal mortality rate. So, how to approach this type of the question? They are asking us perinatal mortality rate. So, first of all, you should be knowing what is the perinatal period and what is the definition of this. पूरे मिस 25 सेशन से कितने क्वेश्चंस आते हैं, मतलब पूरे 19 सब्जेक्ट से, ठीक है बेटा? You can get between 50 to 100 questions. I'll not say the copy paste, but it will be from those topics only. Okay. Now, perinatal mortality rate means any death from 28 weeks of intrauterine life till delivery, during delivery, and first 7 days after delivery. This is what is the perinatal mortality is per 1000 live birth. So, what is the perinatal mortality rate is? It is perinatal deaths divided by total live births into 1000, because it is expressed as per 1000 live births. Now, coming to what are the perinatal deaths? They are saying that between 32 to 36 weeks of the intrauterine life, how many babies die is the 50 babies. So, 50 IUDs are there, and within the first 7 days after delivery, so 2nd to 5 days, the 30 more asphyxiated babies died. So, how many are the perinatal deaths happen? Perinatal deaths are 80. And out of how many of the live births they are happening? They are happening out of 10,000 live births. So, all had started answering correctly, that is the option number B, but we have to see that how we had come to that answer. So, out of the total live births is 10,000. So, we have to convert into 1000. So, your answer will be 8. So, 8 is your correct answer. Now, see, some of you are making a mistake. Now, same like we had discussed in our first question that what mistake you can come across. So, we should be again trying to learn that where we can make the mistakes. So, what will be our mistake number 1? If we are making a mistake in calculating the perinatal period. Now, here the 50 babies had a intrauterine death. 30 babies, they died in first 7 days. That is what is called as, it is called as early neonatal deaths. And 20 more babies had died between the 2nd to 3rd week. And this is what it is, late neonatal mortality. late neonatal mortality. So if you're counting 50 plus 30 plus 20, so how many will be the total deaths? You are counting as 100, and that's why those who are answering the 10, they had included all these deaths. So this is your mistake number 1. Second mistake, what you can do, you can be only including this early neonatal and the late neonatal, thinking perinatal period as the neonatal period. So you may be having the total deaths as 50 only. So if you are considering this total deaths as the 50, your answer will be 5. That is again your mistake. Now the third mistake what you can do, that if you only consider the early neonatal death as the perinatal period, so you may be counting only 30 as your deaths, and your answer will be 3. So those who are answering as 3, that is option number D, that is again wrong. Those who are answering option number A, 10, it is again wrong because they had counted all the 3 periods death. So we are not supposed to include this late neonatal because that is not a part of perinatal mortality rate. Okay. So here the yes multiplying factor is 1000 because it is per 1000 live birth. So here the correct answer for this is, that is option number B, that is 8 is your correct answer. So we should be able to understand that where we can make the mistakes, because that answer will be definitely given in the question. So what happens actually when we appear in the exam with a great difficulty, we try to come to an answer, and if the answer is given in your choice, you don't have a second thought. You think that this answer is the correct answer. You just click and move further. Okay. So now we should be knowing what these periods are, because they can be asking, this time I had asked as a perinatal mortality, next time they can ask you the neonatal mortality, the third time they can ask you the infant mortality rate also. So you should be knowing the different periods. So period between the 0 to 5 year is under 5 mortality. Any death which is happening within first 1 year, it is the infant mortality. Any death is happening within the first month or the first lunar month or the 28 days, it is neonatal. And first 7 days, it is early neonatal. Then 7 days to 28 days or 7 days to 1 month, it is the late neonatal. And early and the late together, they are the neonatal mortality rate. Okay. And the post-neonatal means after the neonate, that is from the 1 month or 28 days till 1 year, that is what is post-neonatal mortality. And all are including early neonatal, late neonatal and the post-neonatal, they are a part of your infant mortality rate. And the perinatal mortality is from the 28 weeks of the pregnancy till delivery, during delivery and the first 7 days. So early neonatal mortality, be very careful. It is a part of perinatal also. It is a part of neonatal mortality also. It is a part of infant mortality also. So no confusion. So how we can remember the formula? That all these deaths in any of the period is, what is the denominator? It is the total live births. If you write in a formula form, it is per 1000 live birth. Okay. So this is all about this topic, and this is flashcard where I had tried to summarize all these mortalities in one page. So try to save this page. This will help you in just recalling or revising within 1 minute just before your exam. And as we all know that social media is time killer. So it is trying to just kill your time. It is trying to drain your mental energy. So you have to keep distance from social media at least for next 32 days. And those who will be keeping a distance definitely will be winner of this game. Next question is, mother brings 8-month baby for routine vaccination who had already received earlier vaccine as per universal immunization program. Which is the correct statement about a vaccine you will be giving at this point? So here what is catchy word? Number 1, that baby is brought when the baby is 8 months of the age. Baby has already received earlier vaccination. So here quickly you have to recall in your mind about our immunization schedule, what we are following under the universal immunization program, that at the birth baby had already received the BCG, oral polio vaccine 0 dose, birth dose of the hepatitis B. Then at the 6 weeks, 10 weeks and the 14 weeks, first and the second, third doses of pentavalent OPV rotavirus. 6 and 14 weeks पे first and the second dose of IPV first fraction, second fraction, and the pneumococcal vaccine first dose and the second dose. Now the baby is coming at 8 months. We know as per our program, the next dose is given when? Next dose is given at 9 months. So you all had started giving the correct answer that we are supposed to give at the 9 month the measles containing vaccine first dose, Japanese encephalitis, vitamin A, pneumococcal booster and IPV third fraction. But as the baby is 8 months and we know that exclusive breastfeed is till 6 months and the immunity or the maternal antibodies last for next 3 months. So we are not giving routinely measles vaccine before 9 completed months. So we are not giving at the 8th month of this age. So this is also not true. Already baby had received the BCG pentavalent 3 OPV as per the routine schedule. So we are not again giving like a J you can give, the IPV you can give and call after 1 month for measles containing vaccine. So what is the best is that no vaccine is given at this time and call the baby after 1 month to give the scheduled vaccine at 9 months. So this is your immunization schedule as per the universal immunization program. So we should be very clear that at what age, what vaccine is given. And very important vaccine is at the 9 month of the age, we are giving the first dose of the measles containing vaccine, pneumococcal booster, Japanese encephalitis first dose, which we are giving in only endemic areas, third fraction of IPV, and very importantly, what they ask is about the vitamin A doses. Okay? So we should be very clear about this. This is prophylactically. So read the question carefully if they are asking the prophylactic dose and the therapeutic, because therapeutic are different from the prophylactic doses. We are starting from the 9 month, between 9 to 12 months, we are giving the first dose. And how much it is? It is 1 lakh international unit per dose, or it is the 1 ml. And if the baby is more than 1 year, baby weight is less than 8 kgs, that dose is 1 lakh. But if they don't mention about the weight, presuming the baby is growing normal, so we will be giving the 2 lakh international unit per dose. So like this, 1 dose below 1 year and the 8 doses after 1 year. So total 9 doses we are giving, and the total amount of the vitamin A what we are giving prophylactically to our baby is, it is 17 lakh international units. Then we are giving at 1.5, 5, 10 and 16 years also. So we should be very clear about this schedule. And as we all know that pregnancy vaccination with the TD is also a part of our this program. Now, some important point is that they can be giving you the image of this baby and they will be putting an arrow to any of the site and they can ask at particular age what vaccine will be given on that particular site, because Government of India has fixed the certain sites for particular vaccines. So if we talk about the left deltoid, what vaccine we are giving? We are giving at birth or at the 6-week age BCG. Then the third fraction of IPV at the 9 month, it is given on left deltoid. Now what we are giving on right deltoid? Right deltoid, if we are giving the first fraction of IPV as well as second fraction of IPV, because first fraction we are giving at 6 weeks, second fraction we are giving at 14 weeks, and at 9 to 12 months, we are giving measles containing a vaccine. So measles containing vaccine, this we are giving in our right deltoid. Now one more we are giving in a left deltoid if we are giving Japanese encephalitis live vaccine, because it is given as subcutaneous route, so it is given in left deltoid. But now in our program, what we are having? We are having the killed vaccine Japanese encephalitis as a preference, which we are giving in left thigh. So what we are giving in the left thigh? We are giving T group of the vaccines, like we are giving pentavalent vaccine, or if you are giving separately at birth is the hepatitis B vaccine, or if we are giving the Japanese encephalitis killed vaccine, it is given in left thigh. Now why we are giving in the thigh, not given in deltoid? Because we are very clear with this that baby, if it is less than 2 years, we cannot give in the deltoid. We cannot give in the glutes. So where we are giving in the anterolateral aspect of middle third of thigh. Okay, so if you are giving separately DPT, yes, you can give, but the pentavalent is including the same. And what we are giving in the right thigh we are giving pneumococcal vaccine. Now what vaccine we are giving through oral route in our program? The one is oral polio vaccine, that is also a Sabin vaccine. We are also giving rotavirus vaccine and vitamin A, that is also a part of this program. So these are the three important vaccines what we are giving through oral route in our national program. But if we talk other than the national program, we are giving very important vaccine through the oral route is live typhoid also. Live typhoid, it is also given through the oral route, as well as cholera vaccine we are giving through oral route. So this is the different routes of various vaccination. This is again flashcards of summary of all the important vaccines what we are giving in our national program. Please save these charts, because here I had highlighted 6-7 points of each vaccine which are asked is that what is the type of the vaccine, what is strain of the vaccine, what is the site of the vaccine, the route of administration of vaccine, dose of the vaccine, schedule of the vaccine when we are giving, what are the side effects, and if it is in the powder form, what is the diluent for this vaccine. So these are again a very, very important flashcards and safe for quick revision just before your examination. Next question is, in a family get together, I notice that my 15-year-old nephew spends most of his time on computer and mobile, as shown in the image. On my advice, now he started using spectacles with blue light blocking glasses to protect his eyes. Level of prevention is. What is the level of prevention in this situation? Now, what are the keywords here is that he had started using the spectacles. For what purpose? To protect the eyes. So it is trying to prevent the condition and already had started using. So all had started answering correctly, that is option number C. But those who are answering option number B, it is primary, no doubt. But it is only not the advice, he has accepted this. If I say I had advised him to use, then it will be a health promotion. But what they say, that on my advice he had started using, so it is specific. And those who are answering as the D, beta, it is not a tertiary, because right now his eyes are not destroyed or damaged. It is trying to protect from the blue light which is coming from, the radiation which is coming from gadgets like mobile or the computer. So it is not a tertiary level prevention. It is not a primordial. Primordial means if you will not use the computer or mobile, that is primordial, avoiding the risk factor. What is the risk factor? Is the use of this laptop or use of mobile, but he is using, so it is also not a primordial. But it is not a secondary, because trying to protect. ऐसा नहीं है कि उसको already damage हो गया है and now he started using to prevent the further damage, then it will be a secondary level prevention. So here it is not a health promotion, because we are not only advising, he has accepted that, so it is your primary specific. So we are having the different level of prevention. So this area is very important, because in the exam definitely they are going to ask a one question, and what we had seen in the previous exam, they never repeat the example. Every time they are giving a new example. So we should be very clear about the concepts of these different level of preventions. So quickly revising the concepts of the different level of prevention. If you are trying to avoid the risk factor or the agent, it is what is the primordial level prevention. So risk factor or the agent is absent, then it will be a primordial level prevention, while in others the risk factor or agent will be present. But in the presence of the risk factor, if you are trying to avoid the disease, it will be your primary level prevention. So disease will be absent in both primary and the secondary. And here again a catch is that most of the time in the secondary level prevention, where we are trying to early detect a disease is present, but in the different type of the screenings where we are trying to identify among the population those who are diseased, so sometimes in the healthy one disease may be absent. So disease may be absent in secondary level prevention also, but usually it is present there. And the complications and the disabilities are usually seen in tertiary level prevention. This is again a very important flashcards where I had tried to summarize the keywords for their level of prevention. They can be making a clinical scenario, giving a prescriptive screening, prospective screening, mass chemoprophylaxis, mass chemotherapy, emergency contraceptives, abortion pills, that what are these different levels of prevention. So definitely this is going to help you in all the type of questions of levels of prevention. हर आदमी चाहता है कि काश उसका अच्छा दिन आए, लेकिन आने का क्या इंतजार करेंगे हम? नहीं, हम अपना टाइम खुद लाएंगे. सो वी विल बी ब्रिंगिंग आवर हैप्पी टाइम, हैप्पी डेज बाय आवर ओन. सो अपना टाइम आएगा नहीं, अपन अपना टाइम लाएगा. एंड इसीलिए कहते हैं कि समय तो एक सिक्का है, एक दिन पलटेगा जरूर. आज आपको लग रहा है कि मेरा दिन खराब है, लेकिन वो एक दिन पलटेगा जरूर. बस तू सिक्का उछालने का हौसला रख, एंड डेफिनेटली द डे विल कम व्हेन द कॉइन विल टर्न एंड एवरीथिंग विल बी गुड इन योर लाइफ. Now coming to the next question. Study started in 2020 on 10,000 individuals. It was noted after 5 years that out of 5,000 obese individuals, 50 developed hypertension, while hypertension was only seen in 10 out of 5,000 normal weight individuals. Observation of this study is, DPT vaccine beta, if you have to give separately, definitely it will be given on left thigh. ठीक है? Till 2 years, means first booster DPT ka we will be giving on our left thigh, but the second booster, because it is given at 5 years, so we can be giving in deltoid. So first of all, with this given question, you have to find out what is this type of the study. Study started in 2020. Study started in 2020. So what is the start point of the study is, it has started in 2020. When we had noted the result after 5 years, means a result we had noted in 2025. So we are moving in which direction? We are moving from this point in the forward direction. Okay. So will it be a case control study? No. So this choice is out. Prospective cohort study? Yes, it could be. But it is not only to identify the study, we had some more points in that. So we have to see whether that is the next portion or the point given in that option is correct or not. So this could be that it is a prospective study. Then retrospective study, it is not there because we had not gone back and then coming to the point. Now coming to the other parameters. So here the 2-in-1 question, the type of the study identification as well as the parameters which we can calculate. Now further go in deep of this question. How many individuals they studied is 10,000. And out of this 5,000 are obese individuals. So we had made a one group of 5,000 individuals and these are obesity is present. It means the risk factor is present. And what is the risk factor? It is the obesity. Then how many are the non-obese individuals where the risk factor is absent? It is 5,000. Now out of this, how many had developed the disease? In obesity individuals, the 50 had developed the disease, and in how many of the non-obese individuals, the 10 has developed the disease. Okay. So now smartly, how you can go for your answer. Now we know that A is not in my choice. So those who are starting with the A is out, this is out. C is not in my answer. So those starting with the C, this is out. Now I am left with B and D. Okay. Now I am left with B and the D. So now what is the B says? Relative risk is fine. What is the formula for the relative risk? Relative risk is incidence in exposed. What is my incidence in exposed is 50. What is the incidence in non-exposed? It is 10. So my relative risk is 5. So yes, I am very sure that my option B is correct. Now I have to choose between option number B and D. This is what I am telling you this smartly, because you had a limited time. So you have to go smartly also for this question. Now what is your attributable risk is 80%. I know the formula for the attributable risk. What is the attributable risk formula is incidence in exposed minus incidence in non-exposed divided by incidence in exposed. What is my incidence in exposed? 50 minus 10 divided by 50. So obviously it is 40 upon 50. So it is your 0.8 or 80%. 0.8 or 80%. So I know that this my option number D, it is also correct. Option number D is also correct. Now, here what I tell you smartly. Smartly is that they had given me the next option, population attributable risk is 80%. Now, always remember, population attributable risk is always lesser than attributable risk. Okay, this is a shortcut gold standard thing. So if you are not going to calculate the population attributable risk, this is how smartly you have to apply your answer. E is not a correct answer. So all had started answering correctly is option number D, it is your correct answer. But for our understanding, we should be calculating attributable risk also. We had calculated already the 80%, and we will be calculating the population attributable risk also for our future understanding. So what is the formula for the population attributable risk is incidence in total minus incidence in non-exposed divided by incidence in total. Incidence in total. Now here you have to do a little bit exercise, that what is the total means, that incidence in exposed, how much is? It is 50. How much is the cases of hypertension? 50 out of 5,000. What is incidence in non-exposed? How many are? That is 10 out of 5,000. So how many are the total disease cases irrespective of the exposed and non-exposed? That is 60 out of 10,000. So we have to convert into a 5,000 figure. So that will be my 30 out of 5,000. So my incidence in total is 30. So if I am coming to this is population attributable risk, that is 30 minus 10 divided by 30. So it is 20 divided by 30, it is somewhere around 66.6%. So always remember, it is a gold standard point that your population attributable risk is always lesser than the attributable risk, and this is how smartly you have to apply your answer. So here the correct answer for this question is, that is option number B, that is it is a prospective cohort study with a relative risk of 5, and attributable risk for this situation is 80%. Now quickly we will be revising all of our studies, because epidemiological studies we are having in the two groups. We know analytical and experimental. From us commonly they are asking the analytical group of the studies, and we are having the 4 important analytical group of the studies: cohort, case control, cross section and ecological. So from the given question you should be able to identify the type of the study. So looking for the direction and whether the disease is present or absent in the beginning of the study. If the disease is absent at the beginning of the study, it will be only the one disease, that is one study, that is the prospective cohort study, while in all it is present at the beginning of the study. If a direction is simply backward, it will be your case control study. If it is forward, it is your prospective cohort. If it is going back and then coming forward, it is your retrospective cohort. If it is at the particular point, then it may be cross-sectional and ecological. Now, if you are getting our data from the individual person as a primary data, it is your cross-sectional. If you are getting the data from the another source, it will be your ecological study. Then the another question has been asked is that what is unit of the study is, in the ecological it is the population, while in rest it is individual person we have to examine. Very commonly they ask is about the parameters, what can be calculated. So we should be knowing that incidence, relative risk, attributable and the population attributable, it is calculated by cohort study. Odds ratio, it is by case control study. Prevalence, it is calculated by cross-sectional study. Okay, and we should be knowing the formulas also, because this is the basis for our numericals. So we should be knowing how to identify the study, what are the different parameters we can be calculating, and what are the formulas for this. So again, this is a very important flashcard. Save this and it will be helping you in the quick revision of all the formulas in the one page within 2 minutes just before your examination. Okay. Now coming to next one is total population of 10,000 was assessed for HIV infection. Out of these, 200 were diagnosed as HIV positive. A new ELISA screening test was applied on same group and the result says 260 positive. Out of which only 130 had the disease. Calculate sensitivity of new screening test. Now, this is a little bit tricky question. And why I had kept here is because this type of the question asked from us in last exam. Okay, in the last January 2025 exam, this type of the question was asked from us. Now, to solve the numericals related to screening, we should be able to fill our values in a 2 by 2 table. But as we are not being given a rough paper and pen, so we have to make this table in our mind. Okay, so I'm just putting table here is for our better understanding, and we should be learning that how to fill value in the table, because you know formulas. Once you are able to fill the values in this, you will be getting your correct answer. So how to approach this type of the question? The point number 1 is that out of the total population of 1,000, 200 were diagnosed as HIV. So how many are the disease cases out of this? It is total disease cases are 200. So obviously, how many will be the healthy individuals out of the total population of 1,000? It will be 800. So this is my first step, that how to get my disease cases and healthy cases. So I'm getting the mixed bag of answers for this question. So let us see. Now the second is what we are saying, a new ELISA test. A new ELISA test applied and says that 260 positive. Although they are saying 200 is only the disease cases, but in how many the test is positive? It is 260. It means some may be a true positive and some may be the false positive. But how many are actually having this disease? Out of the 260 who are positive for this test, 130 had the disease. So the test positive with the disease present is only 130. So what will be in the remaining 130? The test is positive but the disease is absent. They are the false positive. Now I got my 2 values, or out of the 6 I can see the 4 values I am having. So what will be those disease individuals without the positive result, or the negative result is that out of this 200, 130 is positive, so 70 will be having the negative result, and out of this 800 healthy individuals, 130 had the test positive, so remaining 670 will be having the negative test result. So now I am having all the 4 values, and we all know that this is value A, that is true positive, this is value B, that is false positive, this is value D, that is true negative, and this is false negative value C. Now what they are asking, it is sensitivity. So we have to look for what they are asking, sensitivity. Now what is the formula for the sensitivity? It is A upon A plus C. It is A upon A plus C. Okay. So what is my A? It is 130. And what is A plus C? It is 200. So this is coming to as 70%. So 70% is my sensitivity. 70% is my sensitivity. Those who are answering as option number B, because this was, as I say, almost the same numerical which was asked from us in the exam, but what they had asked in the question is specificity. And here I had changed that question, it is sensitivity. So those you might be remembering the answer for that numerical. So a very important take home message is, beta, that never ever mug up the answers for the PYQs. Try to understand the concept, because if examiner is changing one word in that question, your answer will change. And what I had done here is, I had changed the word specificity to sensitivity, and your answer is changing. Now, what mistake you can do here is, now if you are just reading this as the specificity, now what is your specificity is? Specificity is what? It is your D upon B plus D. And what is your B? D is 60, 670 divided by 80. Your answer will be 84%. So 84% is your specificity. This is your first mistake. The second mistake, or what you can do, so this is your mistake. Instead of calculating the sensitivity, you can go for specificity. Now, if you consider this in a horizontal, means if you consider this in the horizontal, so that is actually what is? It is your positive predictive value. So what is your positive predictive value is? That is A upon A plus C. And what the A is? A is your 130 and B is also your 130, sorry, A upon A plus B. So it is 130 divided by 260. So 50% is your positive predictive value. And what is your negative predictive value? If you'll go in this direction, you go in this direction, then what is your negative predictive value is? It is D upon C plus D. And what is your D is 670 divided by 740. So that will be your 90%. That will be your 90%. Okay. So see what they are trying to ask and then remember formula and apply this action in your given question. Okay. So here they are asking you the sensitivity. So you should be knowing the sensitivity formula. So you have to go for sensitivity if they are asking, that is A upon A plus C. If they are asking you specificity, go in this is D upon B plus D. If they are asking you positive predictive value, go in this direction, that is A upon A plus B. If they are asking you negative predictive value, go with this D upon C plus D. Okay. So we will be having all the 4 different parameters for this. So we have to remember the formula and the flashcard I had already shared with you. Now some more questions which has been asked from this topic. So quickly we will be revising. They commonly ask what is the relationship of the prevalence to the predictive value, and they say one test is applied to an area with 10% prevalence, the same test is applied to the area with 50% prevalence. So what will be effect on the positive and negative? So always remember, if a prevalence is increasing, your positive predictive value increase because it is directly proportional, and negative predictive value will decrease because it is inversely proportional. The next question that is asked is, that is test in the series, if we apply, that what will be its effect on the results. Now test in series means we apply a first test, and those who are positive on the first test, then we apply the second test. Always, always, always try to remember with HIV. When we apply first ELISA, those positive ELISA, then we apply the Western blot, and our purpose is to increase the specificity of the result, that the innocent people who are not having the disease, they are out of the race, and we have to increase the positive predictive value, means if a test is positive, definitely you should have the disease. Okay. Don't try to remember all these 8 parameters. I always tell to my students, don't try to remember all these 8 parameters, only remember with the HIV, ELISA and Western blot, these 2 points in the series, the rest 2 will be reduced, and when we apply the test in parallel, means more than one test at a time, opposite will be for the series. The next question that is asked is that effect of cutoff value, means like our cutoff for the exam is 150. What happens if a cutoff goes to 120, and what happens if a cutoff goes to 180? So same is, if I want to increase the specificity of the result, it means the innocent people should be out and only those who are having the disease should be positive, then I have to keep the cutoff to the upper side. So here, what is this shaded area which is above this cutoff? Because this was also one of the question. So all the values above the cutoff will be, it is positive. Okay. But shaded area which is above the cutoff, it is your false positive, and the rest is, it is true positive. Any value below the cutoff, it is negative result. The shaded area that is below the cutoff, it is your false negative, and the rest is it is true negative. So if I increase the specificity of the result, I have to keep the cutoff to the upper side, and if I want to increase the sensitivity of the test, I have to keep the cutoff to lower side. So these are some of the important points which had been asked repeatedly in our previous exams. Then two very important cancers for which we are doing screening. One is cancer cervix and breast cancer. So very commonly asked question is, what is the best screening test for cancer cervix? So wherever you are, just try to revise with me. The best screening test for cancer cervix is what? It is your pap smear test. It is pap smear test, but the problem is that it requires expert cytologists for reporting, which is not possible lower than district hospital level. So it is only possible from the district hospital onwards, district hospital medical colleges. So the next question is that what is your cost-effective screening test which we can perform in the periphery without the use of our cytologist? It is your VIA test and the Willi. But if you have to choose better, that number one preference is given to VIA over Willi. Then another question that they can be asking is the image-based question, and this is an image of your pap smear test. You had already discussed in detail in your gynae classes, and sometimes they can be asking the image of VIA and Willi also. So this is first image where we are applying the acetic acid over cervix for 1 minute, wait for 1 minute, and here we are using a 3 to 5% of the acetic acid, and if we get a aceto-white patch, this is suspicious. So this first test, it is giving the image showing a VIA. What chemical we are using here is 3 to 5% of the acetic acid. The second image which is shown is, it is for your Willi, and what we are doing here is we are applying Lugol's iodine. So if the purplish color we will be getting, that is normal. So which is suspicious, that if you are having the colorless patch or the turmeric yellow color patch, that is suspicious. So remember, which is suspicious in VIA? It is the patch which is having a aceto-white patch is suspicious, and the colorless patch is suspicious in Willi. Now in the breast cancer, what is cost-effective screening test? It is self-breast examination. Self-breast examination, and when it has to be performed? Post-menstrual, because we had a less progesterone there, less tenderness of breast. But best screening test for the breast cancer, if a lady is less than 40 years, so best will be MRI. If MRI it is not available, then you can go with ultrasonography of breast. But if a lady is more than 40 years, then we can go with mammography. So these are some of the important questions which are commonly being asked from this topic. Now beta, you will be getting answer of your question in this slide. Now there is no excuse for not trying. Still, if you are forgetting, you have to read again and again. You have to read again and again, and if you are making any mistake in past, only lesson is do the mistake, forget it, but take a lesson from that mistake forward. So we have to learn from our mistakes, what you are making in past, and taking message, so we will not be repeating those mistakes. Because beta, these all are the practice sessions, whether you are appearing in any GTs or you are doing practice questions. Still, if you are making mistakes, no problem, but you have to identify your mistakes, you have to build up your concepts, so you will not be making these any silly mistakes on our important day of life, 26th of July, in our examination hall. Okay, so there is no excuse for trying. You just do, you try, make mistakes, but learn from those mistakes. बिना पेपर के टेबल नहीं बन पाता है बेटा, दिमाग में एक टेबल बनाना पड़ेगा. ठीक है, 2 by 2 का टेबल बना के 4 कॉलम ही तो रखने हैं, और उन 4 कॉलम में आप वैल्यूज रख लो, एंड देन यू हैव टू मेक अ कैलकुलेशन. करना तो पड़ेगा बेटा, एक्सक्यूज के लिए तो कुछ नहीं है. ठीक है, देयर इज नो प्लेस फॉर एक्सक्यूज. अब पेपर नहीं है तो नहीं है, तो रास्ता तो हमें ढूंढना पड़ेगा. नेक्स्ट इज obstetric history of 35-year woman. First 10-year baby, alive male. Second, stillborn female 5 year back. Third, 3-year alive healthy male. Calculate the TFR and GRR for this lady. TFR or GRR of this lady. So before answering, first we should be knowing what is the TFR. T stands for the total number of the live births born to a woman. So very important is it should be total children born alive. Now again go to the obstetric history. The first 10-year baby, it is alive, so it will be included. Second is stillborn. Stillborn is the dead baby, so it will not be included in this. And third is again 3-year alive, so it will be included. So bachas, those who are making answer as A, be very careful ki stillborn are not included. So out of these 3, how many born alive? 2. So smartly go for choices. TFR 3 is out, TFR 3 is out. So my option number A and B is out because only my 2 children are born alive. Now going to the second point is what is the GRR? G stands for the girl. So how many girl children born alive? Okay, born alive to a lady in her entire reproduction. Only 1 child born female, but that was stillborn. No female was born alive. Now you are getting my point and coming to a correct answer. Still beta, it is not an option C because this female baby which is born alive is what? It is a stillborn baby. So it will not be counted in GRR. It will not be counted because it is a stillborn baby. So it will again not one as a GRR. So correct answer is the TFR is 2 and the GRR is 0. Okay, so to answer these type of the questions, we should be knowing the definitions of these demographic indicators. So 2 very important group of the demographic indicators, the vital indicators and population indicators. Again, I try to cover up their definition in this flash card. Again, save this card. This is very important for your quick revision before the exam. So first 6 are your vital indicators, vital demographic indicators, and we should be knowing the definition of all these. And the next 4 are your population demographic indicators. Okay, population indicators. And sometimes they can ask you straightforward definitions. Sometimes they are asking numerical also, like calculate the sex ratio, calculate the dependency ratio, calculate the crude birth rate and crude death rate. Okay, as I always say that in PSM, any definition is very smartly can be converted into a small numerical. So if you know the concept of that particular definition, definitely you will be able to solve that numerical. ठीक है, तो numericals का tension नहीं करना because we are not a maths person. ठीक है, maths person नहीं है तो obviously हमारा maths उतना strong नहीं है. लेकिन अगर हमें definition का concept पता है तो हम बहुत easily अपना numerical solve कर सकते हैं. So definitions are very important. Next is birth rate and death rate starts declining, but still birth rate is more than death rate, leading to increase in population size. Correct about this phase of demographic transition. So what is demographic transition are? The phases of the demographic cycle, and when we know that 5 phases are there, phase 1, 2, 3, 4, 5. Here we are supposed to remember the number and what is that name of that phase, and what happens to birth, death and the population size and the demographic gap in all these phases. Okay, so first is that is high stationary, means birth rate is high, death rate is high, and population stationary, demographic gap is constant. So you always started answering the correct answer. And the second one is what? It is an early expansion, high birth rate, but death starts suddenly declining. The demographic gap increases, population increases at a very fast rate. Then the phase 3, late expansion phase, birth rate starts decline, death rate starts declining, but still the birth rate is more than the death rate. So it is your late expansion phase, phase 3. India is in which phase? Yes, it is in the 3rd phase of late expansion phase, and demographic gap reduces from the start to end of this phase. So here the correct answer is, that is all of the above are correct, and our answer for this question is option number D. all of you are making correct answer. I am very, very happy that you are not making any mistake in this. It means you are very clear about the phases of the demographic cycle. So this is again a very, very important section. Here in one exam, they'd ask as a straightforward image of this. They can put an arrow to any of this phase and they can ask is what is this line? This is your birth rate. What is this line? It is your death rate. The difference between the birth and the death rate is what is the demographic gap, and this is what is the population. So what happens to the first, second, third, fourth and fifth phase? We should be knowing all about these demographic phases. A very, very commonly asked question and query among all of us. Ki what will be the level of questions or paper, difficulty level of the paper this time? Some says कि दिसंबर का पेपर डिफिकल्ट होता है, some says जून का पेपर डिफिकल्ट होता है. It is very difficult to say. ठीक है, it is very difficult to say. So why we have to worry about the thing which we cannot control? We don't know what will be the difficulty level of the question, but we should be ready to face any type of the difficult questions in the examination. So इसको लेके stress नहीं करना है. So make a promise to all of you that I will not be making or stressing myself over the things which is beyond my control. I cannot control the difficulty level of the question, so why to worry? Only thing is what I can do is improve my study, improve my focus, reducing my mistakes, so I'll be getting a best possible correct answers in the exam. Correct about given image is. So try to see this image very carefully. Okay, correct about this given image is. So first of all, what this image is having the thread hanging from the device. So if a thread is hanging from the device, it is your intrauterine contraceptive device, number one. Now, second is, it is a T-like structure, but you are not seeing copper anywhere. But what you could see is, if I zoom this image, you could see some capsular-like structure, and this is containing hormone. So, what is correct about this is, you had all identified this image as Mirena, but see my choices, okay? It is an intrauterine non-hormonal contraceptive device. No, it is a hormonal device. It is wrong. Can be safely used by lactating women. Yes, it can be safely used by the lactating women because estrogen preparations we cannot use, but progesterone preparations we can use. Now, please, those who are answering C, just be very careful. Daily release is, it is 20 microgram beta. It is not a 20 milligram. This is the catch. It is not a 20 milligram, it is 20 micrograms, so this is also a wrong answer. It is a long-acting, irreversible contraceptive. No. Long-acting means acting for more than 1 month. It is lasting for 7 to 10 years, but it is not irreversible. The tubectomy and vasectomy are the long-acting irreversible contraceptive. It is reversible contraceptive. So again, this is your wrong answer. So the correct answer for this is option number B. So here a very important take-home message is, beta, that I want your concentration for at least 2.5 hours session, first and second, because you should be focusing for each and every word carefully. 20 तो सबके दिमाग में रहता है, लेकिन milligram and microgram, these are the silly mistakes which we can make. Okay? So don't be in a hurry. Yes, beta, I had trapped you and आप फंस गए उसमें. ठीक है? So these are the areas where we should be very, very carefully seeing the choices before marking our answer. Now quickly revise all IUCDs because they are very important image-based questions. So how you can identify IUCD? A thread hanging from this device, it is IUCD. Second is, if it is having copper, it is your copper device. If it is a T-like structure, what this is, it is your copper T. And if it is on both the arms, horizontal and the vertical, it is 380A. And if it is a copper device, but it is not like a T, it is as per the shape of uterine cavity, this is your multi-load. It is your multi-load 375. Then if it is T-like structure, but capsule it is present and thread hanging from the vagina, it is what? It is your Mirana or LNG20. Okay. And Lippes loop, a loop-like structure, and no copper is there, that is Lippes loop. It is your inert device. Now some more questions what has been repeatedly asked from this IUCD section, which is the best time to put the device is when we are very sure of no pregnancy in the previous cycle. So post-menstrual or post-puerperal, 6 weeks after puerperium, or it is post-abortal. Just after the abortion, you can put the device. But as we are not able to catch our patients here is, so we are preferred is postpartum, just after the delivery, within first 48 hours, we are putting the device because our purpose is to have spacing between the next pregnancy. Now, shelf life is again a very commonly asked question. The copper T 388 is lasting for 10 years. Mirana, it is 7 to 10 years. If it is not in your choice, you can go for 5 years. And multi-load 375, it is for 5 years. Now, very commonly, they are asking about the clinical questions about contraindications and the side effects. Now, there are certain absolute contraindications is if there is a current PID, if undiagnosed bleeding per vaginum or the suspected pregnancy, and in this order you have to choose because one question was asked where the two absolute contraindications was given in the same question, so we have to choose in the order. So first priority is to the PID, and there could be some relative contraindications. There is a past history of the PID, anemia, or the multiple partners where there is an increased risk of this. Now, most common side effect what is seen is menstrual irregularity. Don't jump for removal. This is the question what they ask is, we have to reassure the person, body will take 2 to 3 months time to adjust. But simultaneously, we are giving iron folic acid because patient is bleeding and tranexamic acid to reduce the bleeding. But the question says that a patient is coming with any sign and symptom of pelvic inflammation, immediately we have to remove the device because foreign body, if it is present, infection cannot be corrected. And then we have to give antibiotic. Now, another question is asked is if your device is displaced or it has perforated, if it is displaced inside the uterine cavity, then we have to remove through hysteroscope. But if it is perforating and going outside the uterus in the abdominal cavity, then we have to remove with laparoscopy. Okay. Then another question that is asked is what is a long-acting reversible contraceptives? Okay, be very careful. Irreversible if it is the tubectomy and vasectomy, then long-acting reversible contraceptives we can be having hormonal and non-hormonal. So non-hormonal is your copper IUCD, maybe your copper T or maybe your multi-load. Copper T or multi-load. Okay. One more question is that what these numbers are denoting is, it is the surface area of the copper in square millimeter. More is the surface area, the longer is the duration of action. Then what could be the hormonal long-acting reversible device? The hormonal long-acting reversible device, one we had already talked as Mirena. Second is we are having implant or Norplant as well as DMPA injection. Implant, Norplant or DMPA or hormonal injection. Can you just message me that what is the name given in our national program for this DMPA injection? What is the name given to this DMPA injection in our national program? I am waiting for your reply. Dr. Amil Beta, it is not the Chaya because Chaya it is for non-hormonal oral tablets. Yes, rest all are very correct. It is Antara. Beta Saheli, it is the same name, brand name given for the Chaya tablet. So yes, it is Antara, not the Saheli. ठीक है, Saheli के लिए it is the Chaya है, that is non-hormonal oral tablets है, okay? And injection, DMP injection, the name given in our national program is, yes, you are all right. So at least just clap your back, okay? And just be happy that you are confident in your studies, you are focusing well, you are able to answer questions. So don't worry. अभी इस समय आपको लग रहा है कि मुझे याद नहीं आ रहा है, मैं हमेशा पढ़ता हूँ पीएसएम, बार बार भूल जाता हूँ, याद नहीं आ रहा है, लेकिन डोंट वरी, व्हेन यू सी द चॉइसेस ऑन योर कंप्यूटर स्क्रीन इन द एग्जामिनेशन, इफ यू हैव डन अ मल्टीपल रिविजन, डेफिनेटली यू विल एबल टू रिमेंबर answer for this. This is again a very important flashcard, and the question is asked is, which is the contraceptive of choice in the certain situations, like in a young adolescent we prefer the barrier because it is protecting against the STDs also. If you want to delay the first baby in a recently married couple, we prefer OCPs. If we want to delay the second baby, we prefer IUCDs. So these are a list of contraceptive of choice in certain situations. If you want to compare passing percentage of boys and girls for missed students in January 2025 FMGE exam, which test you will be using? So here we have to first see in the question whether they are talking about a qualitative variable or the quantitative variable. How we can identify passing percentage? So if they are talking about the percentage or the proportion, it is what? It is your qualitative variable. But if they are talking about the mean, median or the standard, so not the median, the mean and the standard deviation, it is a qualitative variable. Okay, so it is a quantitative, sorry. So if they are talking about the mean and the standard deviation, it is quantitative. They are talking about the percentage or the proportion, it is qualitative. So it is, one is qualitative variable. How many groups they are comparing? They are comparing the two groups, one for the boys, another for the girl. So two different groups they are comparing. Then yes, beta, we are using chi-square test. So those who are answering option number B, beta, why it is not an option number B? Because one thing is that we are not comparing the same group. We are comparing boys to the girls. Second is we are not comparing with the quantitative variable, we are comparing with the qualitative variable. So if you are comparing the two, quantitative variable, we will be using the student t-test, same group, before and after intervention, it will be paired, two different groups. If it is unpaired, more than two groups, we are comparing quantitative variable, it is ANOVA test. But if you are comparing the two same groups, qualitative variable, sign test, and if it is two different groups or more than two groups, it is chi-square test. So here the correct answer for this is, it is your chi-square test. So this is a chart showing. So first of all, in this type of the given question, you have to look for point number one, it is a quantitative variable or it is a qualitative variable, because if it is parametric test, we are using for which type? We are using for the quantitative variable, and non-parametric test we are using for the qualitative variable. The second point is you have to see whether the two groups we are comparing in the quantitative variable, then we will be using the student t-test, two same groups before and after intervention, pair t-test, two different groups, it is unpaired t-test, more than two, it is ANOVA test. But two same groups, qualitative variable, sign test, two different or more than is, it is chi-square test. Now one thing which is irritating all of us is fear about the result of our exam. What will happen? Whether I will pass this exam or I will not pass this exam. So this is a natural thought which may be coming in mind of all of us, but हमेशा याद रखना कि everything you ever wanted is on the other side of fear. आपको डर छोड़ना पड़ेगा. And कैसे आप डर पे कंट्रोल कर सकते हैं? If you are working hard and if you had self-confidence, so work hard, believe in yourself, have a self-confidence that I am doing my duty honestly to more than 100%, and just leave everything on God. If you are doing good, then definitely good is going to happen with all of us. Okay, so don't waste your time in thinking what will happen. Just utilize the time in performing the things. Calculate range of 68% population with mean value of 85 with standard deviation of 2.5. So here, first of all, we should be knowing that how much of population is covered in standard deviations. Now 68% or 68.3% population is covered within plus minus of 1 standard deviation of mean. It is within plus minus of 1 standard deviation of mean. Now what is here the mean value? Mean value is 85. How much is the standard deviation? How much is the standard deviation is 2.5. So it is 2.5 less and 2.5 more of this 85. So all are answering very correctly. The answer is it is 82.5 to 87.5. So yes, this is which is covering plus minus of the 1 SD. So definitely how much of the population it will be covering? It will be covering 68% of the population. Yes, you all are answering very correct. So I'm very happy that concept is clear. Now when this answer will be 80 to 90, it is covering the range of plus minus of the 2 SD. Okay, and how much of the population it will be covering? It will be covering the 95% of the population. Now when the answer will be 77.5 to 92.5, 77.5 to 92.5, this is covering plus minus of the 3 SD of the mean value, and this is covering 99% of the population. Okay, and outside the 82.5 to 87.5 means 68 inside, so how much will be the outside? It will be the 32% will be outside of this range. So this is how you have to approach to this question. Yes beta, 99% or 99.7 more specified you can say. So this is a normal distribution pattern, very commonly asked and is a numerical based question, and it is a Gaussian curve or the bell shape. The first question that is asked is, what is the relationship between the mean, median and the mode in a normal distribution pattern? It is all equal. Then how much is the percentage of the population covered within plus minus of the 1 standard deviation of the mean is 68.3%, plus minus of the 2 standard deviation of the mean is 95.4%, plus minus of the 3 standard deviation of the mean is 99.7%. Now if it is an abnormal distribution pattern, then again the question is asked is, if it is a right skewed, then what will be the relationship between the mean, median and the mode? In right skewed, mean is highest, followed by median and followed by mode. And opposite happens in the left skewed, the mode is maximum, then it is followed by median and it is followed by mean. So lowest in the left skewed is mean and the lowest in the right skewed is mode. 100 teenagers living in a summer sports camp, 75% of them were vaccinated for chickenpox. One candidate X was diagnosed as chickenpox 3 days after start of the camp, and 12 more diagnosed as having chickenpox 2 weeks later. Calculate secondary attack rate. Okay. So first of all, we should be knowing what we mean by secondary attack rate. Secondary attack rate means secondary cases. Secondary cases means those cases which are having an infection from primary case. Okay. In a single incubation period out of the total susceptibles. So to further understand this is, try to segregate the values in these steps. Now how many are the total children? Total children are 100. Out of them, how many are vaccinated? 75% are vaccinated. Okay. So how many children are vaccinated is 75. So obviously they are not susceptible. So the first step is that how many are susceptible left is 25. This is your first step, that you have to exclude vaccinated one. Now first case of the a chicken pox is 3 days after the start of the camp. 3 days after the start, still I am saying this is a primary case. Why? Because the incubation period is for the chicken pox, it is around 14 to 16 days. So might have had the infection from somewhere. So this is the first case which is appearing. Now again, so first case of the chicken pox is 3 days after the start of the camp, now having a natural immunity. So this is again immunized naturally. So it is not now susceptible. So susceptible left are 24. And out of this susceptible, how many are the secondary cases? Secondary cases are 12. So secondary cases of the chicken pox are 12. Now coming to your answer of this question, that what is the formula for the secondary attack rate? It is secondary cases are how many? It is 12. How many are the susceptibles? That is 24. It is multiplied by 100. So it is your 50%. So 50% is the correct answer. Now see that at what point you can make the mistake. So it is very important to understand the mistakes what you can do. Mistake number 1 is, which many of you are going with, that if you are including this 25 as a susceptible, not excluding the primary case, okay, not excluding the primary case, so what can be your answer? It is 12 divided by 25. 12 divided by 25, so answer may be 48%. This is your one mistake. If you are calculating this primary case as a secondary case, so you may be going 13 also. And if it is 13 divided by 25, you may be getting answer as 52%. As some of you are answering, it is again your mistake. Okay. So you have to exclude the primary case. You have to exclude the vaccinated individuals to get your susceptibles, and out of that susceptible, how many are the secondary cases in one incubation period. How I can say it is one incubation period? What they say, that 2 weeks later. 2 weeks later. So this is a catch. You should be knowing the chicken pox incubation period, it is 14 to 16 days. So 2 weeks later is, it is almost 14 days later. So in a single incubation period you are having, because this type of the question asks 2 exams back from us in exam. So that's why I thought let me discuss this question here. डरना नहीं है बच्चों, अपना काम करते चलो, and just be self-confident. And इस किसी ने सही कहा है, लहरों से डर कर नौका पार नहीं होती, कोशिश करने वालों की कभी हार नहीं होती. Just go on trying. Our main work is, main duty, focus on the studies, just have a multiple revisions, trying to build up the concepts, apply that concept while solving the questions. If you go on working hard on your side, definitely no one can stop you from getting success in examination. A 32-year widow lady is working in village as Asha worker after adequate training. She is responsible for. Okay, so they are asking about Asha worker, motivation for hospital delivery as a part of GSY scheme. We know that she is a main worker of the GSY scheme and it is for motivation of the hospital delivery. So yes, this is the true statement. Okay. Conducting the nutritional awareness activity once a month in village. She is not conducting the nutritional awareness activity. Actually, she is motivating the person to go to ICDS center and Anganwadi worker is conducting. So this is your false statement. Responsible for 5 visits for the baby after normal vaginal delivery. 5 visits to the baby after normal vaginal delivery under the home-based care of the young child. Yes, it is also a true statement. Responsible for birth weight recording in case of the home delivery. Yes, it is also a true statement. And she is a part of Gram Panchayat yes, this is a true statement. Okay, so only the one statement is wrong, that is the B. Okay, so how smartly you have to go with your answer, that B, it is out. Now we are left with the two choices, A, C or D, or A, C, D and E. So you all are answering very correct. It is option number D, that is the function of ASHA workers. So we are very have important workers having in the community as grassroots level workers, and the two workers are very important, ASHA workers and Anganwadi workers. So sometimes they can be asked as a picture based question. So she is an ASHA worker who is taking, this is an ASHA worker who is taking a pregnant patient to the hospital at the time of delivery, labor pains, and along with this patient, the relatives are also going. And in other time, she is giving health education to the community to go for MCH care, getting their children vaccinated, then taking care for good nutritive food, hygiene and all. And this is the picturized form of Anganwadi workers. She is responsible for growth monitoring in the ICDS centers. She is also giving vaccination. She is responsible for non-formal school education as well as distributing midday meal. So we are having a very important worker, ASHA worker, and many questions has been asked. His full form is Accredited Social Health Activist, and she is posted in rural areas, and the counterpart for this is the Usha worker in urban areas. The first question, she is a part of which program? She is affiliated to the National Health Mission. Now this is called as Pradhan Mantri Samagra Swasthya Mission, and she is for a very important activity, that is a JSY scheme, Janani Suraksha Yojana, for promotion of hospital deliveries. She is also conducting the other activities like distributing contraceptives at home. Another question is asked is that she is a worker for active surveillance for what diseases? She is a worker for active surveillance for these 4 diseases: TB, leprosy, filariasis and the leishmaniasis, except for malaria. And the worker for malaria is multi-purpose worker, male is active worker for malaria surveillance. Now she is conducting the home-based newborn care, and the visit depends upon the place of the delivery. Now 7 visits if it is the home delivery. Vaginal hospital delivery, it is 6 visits because patient is discharged after 48 hours. If it is a hospital operative delivery, it is 5 visits because patient is discharged after 5 days. Now, when we are conducting, this is again important, we will try to remember. If it is a home delivery, we are starting, suppose today is a day 0 when delivery has taken place, it has to be started from the next day, that is day 1, then day 3, then day 7, then day 14, 21, 28 and 42. So these are the 7 visits, but in the hospital vaginal delivery started from the day 3, and in the hospital operative delivery started from day 7. But be very careful that home-based care of the young child, now it is started from 3rd month onwards. It has no connection with route of the delivery, place of the delivery. So it is for all, it is common. 5 visits we are giving for the home-based care of the young child, and it is given on the 3rd month, 6th month, 9th month, 12th month and the 15th month. Okay, 3rd, say 3, 6, 9, 12 and 15, rule of 3, it is for the infants actually. Okay, then she is distributing TB medicine called as DOTS agents. She is affiliated to Gram Panchayat. Again, a very important question because she is posted in village. She is a member of Village Health Sanitation and the Nutrition Committee. That's why supervising the construction of toilet. This was also one question asked, that what are the functions of ASHA workers, but always remember ASHA never conducts the delivery. Okay, she is motivating the patient to go to ICDS centers where the nutrition is motivation or the nutritional education camp is conducted once a month in the ICDS centers. Very important impact indicator for functioning of the ASHA worker is IMR, okay, and she is also responsible for weight recording and registration if it is a home delivery. Now, coming to selection criteria and the question what you are asking is that she should be a female, 25 to 45 years, 10th pass. If 10th pass is not available, we can go with the 8th pass also. And training duration is, yes, it is 23 days. The married widow or the divorcee is preferred over the unmarried because she is staying in the same village. We are training and she is staying in the same village. If we are training unmarried girl and if she gets married, she is going to another village. So your training is wasted. It is same like आजकल होता है ना colleges में bond लेते हैं आपका कि if you are doing an MBBS or the MS MD from a college, you have to serve that state for a certain time. So this is sort of a bond guidelines is there that we are preferring the person from the same village having good communication skill. And another important point is the population coverage. Now, no confusion. Till today, it is 1 per 1,000 population. 1 per 1,000 population for the ASHA in rural areas. And if it is for USHA, that is urban component of ASHA, it is 1 per 1,000 to 2,500. Although for the ASHA, we are planning or we want that there should be a 2 ASHA worker per 1,000, but not yet implemented. So answer for your exam is that is a 1 per 1,000. Yes, beta, anything widow or married or the divorcee, if a 10th class it not available, we can go with 8 pass. Okay. Now, incorrect about a school health program. Now, it is under Ayushman Bharat program. Ayushman Bharat program ke under, yes, now the school health is under the Ayushman Bharat program. The 2 program has included under the Ayushman Bharat program. One is the school health and the second one is that is health and wellness centers which are giving primary level care. Now they are called as Ayushman Arogya Mantras. They are also under school this Ayushman Bharat program. Trained teachers is health and wellness messengers. No. Health and wellness messengers are students, but the trained teachers they are the health and messengers. What? It is health and wellness ambassadors. So this is your false statement. Okay. Health related activity as iron folic acid distribution is on every Tuesday. Yes, we are having the Tuesday for the health related activities in school. Minus type of the desk in the school. Yes, it is again a true statement. Applied nutrition program is funded by WHO. No, it is funded by UNICEF, where they are motivating to develop the kitchen garden in those schools where sufficient land is available. So, option number B, it is wrong. Option number E, it is wrong. So, how quickly, smartly you have to choose your answer. Wherever there is B, it is not the answer. So, this is out from here. Where the E is there, it is also out. So, only option left is option number D. Okay. Option number D is the correct answer. So, when this multiple choice questions are asked is, so take your time, see your choices, those which are false. So, first you have to exclude them and from the remaining you have to go with your correct answer. So, school health program is a very, very commonly asked area nowadays in our exam. So, school health is under now Ayushman Bharat program. It is under the primary health centers. So, medical officer is responsible for the health checkup, and activity which is done every 6 monthly is the health checkup, eye checkup and deworming we are doing every 6 monthly. Iron folic acid we are distributing weekly and daily we are giving midday meal program. The next question is that deworming days, it is the 10th of February and the 10th of August are the national deworming days is there. Incorrect about the school health. Yes, beta. I think अपने ही क्वेश्चन में मैं ही ट्रैप हो गई. ठीक है, अपने ही क्वेश्चन में मैं ही ट्रैप हो गई. So incorrect is that is, so answer for this is, I am extremely sorry here is that answer for this is that it should be B and E. So I am extremely sorry. So ये होता है ट्रैप. ठीक है, कभी कभी अपने ही क्वेश्चन में खुद भी ट्रैप हो जाते हैं. सो हियर द करेक्ट आंसर इज, बिकॉज दे आर आस्किंग इनकरेक्ट अबाउट द स्कूल हेल्थ, सो इट इज बी एंड ई. Yes, beta. Thank you very much for pointing it this because the correct is that is your A, C and D, but the incorrect is B and E. So C, option number C is your correct answer. Now, school health mein, so we should be knowing what actions are done every 6 monthly, what are done weekly, daily. Then who is doing eye checkup? The eye checkup is done by teacher, will be your first answer. And teacher is checking the eyes for 150 students. And if the vision she finds less than 6/9, then the baby is being referred to the Vision Eye Center for correction, where paramedical ophthalmic assistant is checking for a vision. Then we are having minus type of the desk in school. Space required is per student is 10 square feet per student. And each and every point has been asked in our question. The door and window area should be equal or more than 25% of floor area. And health and wellness ambassadors are the teachers, and health and wellness messengers are students. And UNICEF is funding for applied nutrition program, and Tuesday is the day for nutrition related activities in school. I can understand the phase which is going now, it is crucial for all of us, and we all are the human beings, so obviously we might be under some stress. But why to affect our mental and the physical health because of this stress? And जब ज़्यादा स्ट्रेस होता है तो और उल्टा हम फोकस नहीं कर पाते, हमारा और टाइम वेस्ट हो जाता है, फिर हम और स्ट्रेस में आ जाते हैं कि अरे हमारा तो टाइम वेस्ट हो गया, हम तो पढ़ नहीं पाए. सो व्हाई टू वेस्ट अवर प्रेशियस टाइम इन अ सिली नॉनसेंस थिंग दैट इज स्ट्रेस? सो जस्ट go on working hard, focusing on your goal, give your more than 100% and leave everything on God. Correct about following. So we have to look for correct statement about the following. Kilkari, it is mobile application with weekly audio messages. So yes, this is a true statement. Mobile application with weekly audio messages. Pradhan Mantri Surakshit Matritva Abhiyan, 5,000 rupees cash incentive for primary gravida delivery. Now 5,000 cash incentive for the primary gravida we are giving in Matru Vandana Yojana, not the Pradhan Mantri Surakshit Matritva Abhiyan. Surakshit Matritva Abhiyan, what it says, it is the free antenatal checkup on 9th of every month. So this is your false statement. Okay, false statement. Step approach, it is surveillance of communicable diseases. Surveillance of communicable diseases, no, it is for the non-communicable. So this is also your false statement. Chaya, as we had recently discussed, it is a non-hormonal contraceptive tablets. So it is again a false statement because it is not a hormonal tablet. So only left true statement is, that is Kilkari, option number A. So option number A, it is present in all, but rest all are wrong. So this is a wrong choice, this is a wrong choice. So only the correct answer for my question is option number D, that is Chaya is non-hormonal. Okay, so this is also a false statement. So the correct answer for this question, that is the correct statement, is option number D. Now here we should be knowing certain logos and certain activities and what we are performing in that. So first logo is our logo for National Health Mission or the Pradhan Mantri Samagra Swasthya Mission. Okay, this is related to all MCH activities. Suman is Surakshit Matritva Ashwasan, where we are having zero preventable mortality in mother and newborn. This is your logo for Janni Shishu Suraksha Karyakram, JSSK scheme. It is the logo for Arman, advanced reduction in mortality and morbidity in mother and a newborn baby. Laksh, it is improving labor room quality for good MCS services. Logo for Pradhan Mantri Surakshit Matritva Abhiyan, it is 9th of every month free antenatal checkup. Matru Vandana Yojana, 5,000 rupees cash incentive for primary gravida in 2 installments. First 3,000 rupees and then 2,000 rupees after delivery, 6 weeks after delivery. K, it is logo for Kilkari app. Audio messages are there. Step approach, it is for non-communicable disease surveillance. Antara, it is your injection, that is also known as DMPA injection. Chaya, it is non-hormonal oral tablets. And this is your phenomena which we are using for hypertension, that is a rule of half. So these are some of the important activities, and these are very important flashcards where I try to summarize all these important activities, one line about that. Some had been asked in our previous exams, like in one exam they had asked about the ANMOL, that is ANM online we are having. In the last exam they had asked us about the SAPNA, it is a musket for our leprosy eradication program. So like this, so this is a very important flashcards, and try to save these flashcards, and this will be helping you again in quick revision. Okay. Yes, beta, it was difficult for me to include all the logos in this. So yes, portion logo is missing. Little in Tamil, beta, I don't know Tamil. Sorry. Okay. These are again a very important flashcards where similar words are there, and some of them had been asked in the exam. Like in one exam they had asked about the NICSHE, it is a tuberculosis software. In one exam they had asked about the Ujjwala scheme, that is prevention of human trafficking, home-based newborn care, home-based care of the young child. Okay, so be very careful about this. Under the given program logo, the correct about the program is, this logo is given for Anemia Mukta Bharat program, and we know that this is for prevention of anemia, which is one of the very important indirect cause for maternal mortality ratio. 5 into 5 into 5 strategy, no, it is wrong, because for the anemia we are having 6 into 6 into 6 strategy, 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. 5 into 5 into 5 strategy is for RMNCHA plus N, reproductive, maternal, neonatal, childhood, adolescent, and nutrition. So this is having 5 into 5 into 5 strategy. So this is your false statement. Frequency of prophylactic RNAs twice weekly in 0 to 59 months. We are not having this age group as 0 to 59. We are having this 6 month to 59 month, because first 6 months we are not giving prophylactic iron. So this is also a wrong statement. Lactating mother, red color tablet weekly. No, we are giving daily. So this is also a wrong statement. 14-year adolescent girl, 60 milligram elemental iron and 500 microgram of folic acid, blue color tablet weekly. So yes, you all are answering very correct, that option D, it is your correct answer. So this is a very important program where we are having 6 beneficiaries. So we should be knowing about the 6 beneficiaries, that is from 6 months to 59 months, then 5 to 9 years, 10 to 19 years, then women in the reproductive age, lactating women, and pregnant women. Then 6 interventions we are having, at least try to remember the 3, weekly or bi-weekly or the daily prophylactic iron folic acid, depending upon the situation. We are having a deworming with albendazole, and we are also having food fortification. And the strategy what we are having, we are testing those who are anemic, we are treating and trying to talk about their nutrition habits. The strategies test, treat, and talk. Okay, so we are having the different strategies. So this is again a very important flashcard where I try to summarize the different strategies, that what are the strategies like test, treat, and track for malaria. Test, treat, and talk is about anemia. We are having prevention, test, and treat for HIV. We are having test, treat, and completed treatment for tuberculosis. Like safe strategy, it is for trachoma. So these are some of the important strategies are there. If we talk about this program, so we should be at least knowing in detail about the prophylaxis in the different beneficiary groups, that what is the frequency of administration, what color of the tablet, what is the composition of the tablet. So in 6 months to 59 months, what we are giving is twice in a week, bi-weekly. Okay, then 5 to 9 years, 10 to 19 years, 20 to 49, we are giving weekly. That is also sometimes written as weekly iron folic acid supplementation. Pregnancy and lactation, we are giving what? We are giving daily. Coming to the color, pregnancy, lactation, and reproductive female, and this color of the tablet is a red color tablet. In adolescent, we are having blue color tablet. In a 5 to 9 year child, it is pink color tablet. And obviously, in a smaller baby, this is in the syrup formulation. Syrup dose is 1 ml what we are giving, okay, 1 ml. It is containing per dose 1 ml, 20 milligram of elemental iron and 100 microgram of folic acid. The adult one is 60 milligram of elemental iron and 500 microgram of folic acid from 10 years onwards, and in between बीच की डोज है, ठीक है। तो बीच की डोज क्या है, 400 माइक्रोग्राम ऑफ फॉलिक एसिड एंड 45 मिलीग्राम ऑफ एलिमेंटल आयरन. सो बी वेरी केयरफुल अबाउट दिस. Mix and match choices has been given in different questions, so read the question very carefully. Now, many messages repeatedly I am getting, मैडम अब नहीं हो पा रहा, मन करता है छोड़ दो सब और भाड़ में जाए एग्जाम, मेरे को नहीं देना एग्जाम. So don't think like this, beta. If you give up at this moment, what is the point of struggling so hard in your past 5 to 6 years? Remember year 2018-19 when you had gone for your medical college. You had faced so many challenges there. You might be a very naughty boy and girl, but you had tried to sacrifice all your hobbies, all your activities. You had focused on your studies only. For this reason that you have to appear in your FMGE exam, you have to clear and you have to just be able to get a DR written in front of your name and having eligible to wear the white coat, having stethoscope around your neck. So at this point you cannot quit. छोड़ ही नहीं सकते आप इस point पे. Okay? So just a matter of another 32 days. सिर्फ 32 दिन बचे हैं, ठीक है, ऐसे निकल जाएंगे पता ही नहीं चलेगा. So just focus on your goal and work hard. Mother brings her 3-month-old baby to clinic with complaint of some white spots on eye. On examination, the doctor finds white spots. Management of this case. So what doctor finds is white spots. And when we can get the white spots? In vitamin A deficiency. And what is the age of this baby is 3-month-old. So point what we know, that prophylactically we are administering vitamin A from 9 months onwards. But if any symptom of the deficiency or the sign of the deficiency, we have to treat at that particular point only. This is a basic funda you have to remember. So therapeutic dose 3 lakh, 3 doses, 0, 1 and 14 days to mother. Thinking mother is breastfeeding? No. If baby is having deficiency, so we have to give to the baby, so there is no need to give the mother therapeutically. Although prophylactically we are giving 3 lakh international unit of vitamin A to mother just after the delivery, but therapeutically we are not giving to mother. Therapeutic 50,000 international unit, 3 doses, 0, 1 and 14 day to the baby. Yes, those who are answering B, it is the correct answer, because the dose for a 3-month baby is 50,000 international units. Okay. Prophylactic vitamin A started early. Single dose of 1 lakh to baby, then every 6 months. There is no need for the prophylaxis, because now already having the deficiency symptoms, so first we have to treat. So this is also a wrong answer. Prophylactic single dose of 3 lakh to the mother and the single dose of 50,000 to the baby. No, it is also a wrong answer. So the correct answer is we have to treat the baby. So very commonly the question that is asked is that how much should be the dose for the treatment. So 3 doses we are giving. When we are giving, that is day 0, day 1 and 14 to 28 day. Means today if we are starting, that is considered as a day 0. Tomorrow same dose and after 2 to 4 weeks. And if you have to choose between this, is the best is it is after 2 weeks. The next is how much amount we are giving. Don't make any confusion. 0 to 6 month agar baby hai, so dose is 50,000 international unit per dose. 50,000 international unit per dose if a baby is between 0 to 6 months. Okay? Then if it is 6 to 12 months, then yes, you are very right. It is 1 lakh international unit per dose. And if a baby is more than 1 year, depending upon the weight, less than 8 kgs, then that particular dose is 1 lakh international unit per dose. But if a baby is growing normally, more than 8 kgs, it is the 2 lakh international unit per dose. Some more important questions has been asked is that what can be the WHO classification for the severity of vitamin A deficiency, that is what is called as xerophthalmia. So we should be knowing what are the primary signs and the secondary signs. Then first symptom, the first symptom, be very careful, it is the symptom. The first symptom is, it is night blindness. But what is the first sign? It is dryness in the conjunctiva, that is conjunctival xerosis. But a very important question, most common clinical sign for the screening, because we cannot look for the conjunctival xerosis, so it is your bite spot. So bite spot, it is looked for screening or of the deficiency symptom in children. The most sensitive screening test is, it is the serum retinol level. Serum retinol level. Now another very important question is asked is, when we can say it is a major public health problem, when the prevalence of night blindness, it is more than 1%. When prevalence of bite spot, how much? If it is more than 0.5%. And the prevalence of serum retinol level less than 10 microgram per ml, if it is more than in 5% of the population, we say it is a major public health problem. And again, I repeat, don't confuse with the prophylactic dose and the therapeutic doses. Prophylactically, how many total doses we are giving? The 9 doses we are giving as per our universal immunization program. The total amount we are giving 17 lakh international units, but therapeutically depending upon age of the baby. So these are some of the important points about a very important program, vitamin A prophylaxis program. Identify vector responsible for which the ASHA worker conducts survey, and in the doubtful cases, the thick blood smear is prepared and medicine is distributed for the confirmed cases, and outdoor fogging is done for vector control. So here, first of all, from the given clue, you have to identify what disease they are talking about. So one is, ASHA worker is doing the surveillance. So ASHA worker is doing the surveillance for the one vector-borne disease as filariasis, second vector-borne disease as leishmaniasis also, okay, because malaria ke liye it is multipurpose worker male. Second is, it is thick smear is prepared. Are we preparing the thick smear for leishmaniasis? No, it is for filariasis. It is detected by only thick smear, because malaria is detected by both thick and thin, but filariasis is only by the thick smear. And as this filariasis and the leishmaniasis, Japanese encephalitis, because here the Japanese encephalitis is not a disease for which surveillance is done by the ASHA worker, but it is caused by a vector. That for this we are doing an outdoor fogging for the Culex. So Culex borne disease, it is detected by the thick smear. ASHA is doing the worker, so they are talking about the disease as a filariasis. So first of all, you have to find out what the disease is. Now second is, you have to look for that filariasis is caused by the Culex mosquito, and if I just label, this is the A, this is the B, and it is the C and the D, you all had started answering correctly. That is left corner, yes, because I didn't mark them, and so it is sitting parallel with the white dots, so it is which mosquito? Aedes. It is sitting with an angle to the surface, A for Anopheles. So answer, you all are correct, giving the answer is this mosquito C, which is sitting parallel without the white dots, is your Culex mosquito, and it is your scent fly with oval shaped wings having cilia. It is your scent fly. So we should be knowing about these vectors, their images, and what diseases they are causing. And in detail, if we talk about the various mosquitoes, some of the important points we have to remember, because had been asked in the exams earlier that to identify only the one mosquito sitting with an angle, A for Anopheles sitting with an angle, that is your Anopheles, and that's why its larva बच्चे हमेशा पेरेंट्स का अपोजिट करते हैं, so it is sitting parallel to the surface. Rest all the larvas, they are hanging because their adults are sitting parallel. And the question further had been asked, because in the last exam they had asked this image and identify these larvas. So sitting parallel is the Anopheles larva, and with an angle rest of the larvas, Culex and Aedes. And if it is attached to the roots of the water or the plants, it is your Mansonian. Okay, and the next question, that what chemical we are using for killing these Anopheles larvae which will be blocking the surface, it is your Paris green dust. And here for the Culex, Aedes and the Mansonian, we are just putting the chemical which is dissolving in water. So we are using abate or Tamifos. Remember, it is not a Tamiflu. Tamiflu, it is the medicine or oseltamivir what we are using for treatment of influenza. It is Tamifos. Then we should be knowing some important points, that what is the site of the bleeding, because it is helping in the control. Aedes, it is bleeding in artificial water collection. If we can avoid the all Aedes borne diseases. Mansonian are breeding with the water bodies which is having aquatic plants. Fresh water may Anopheles, and dirty water of the septic tank is Culex, and that's why it is called as nuisance mosquito. Okay, and Anopheles is called as sophisticated because it is breeding in fresh water. Then wings are spotted in Anopheles, but the body is having spots in Aedes, and Aedes can fly only up till 100 meters. So 400-meter radius is kept free from artificial breeding sites at A post and C post. This is very important to prevent yellow fever in India for the yellow fever quarantine conditions. Always try to give nutrition to your brain, because this has to work. So be very careful about your diet in the next coming 32 days. You have to take nutritive food. Try to avoid or to lesser down the junk food, okay? Because junk food से digestion में heaviness आती है, all the blood goes to stomach for digestion of that food. Brain को लगता है खाना नहीं मिल रहा, नींद आने लगती है. So try to have lighter food, preferably homemade food if you are at your home, and if you are in hostel and away from your home, try to take light food, avoid junk food, take fruits and vegetables in your diet, maybe adding some dry fruits also, because the brain shape is like a almond shaped, and you have to take more of so not a shape of almonds, it is a walnut shaped, so more take of walnuts in your diet, as well as you can take almonds also, which is improving your memory and giving good nutrition to your brain. Next is a patient with 2 hypopigmented anesthetic patches with 1 thickened nerve and muscle weakness in supplied area presented to you. You had diagnosed the patient as leprosy and started the given pack of leprosy. Correct about this. So first of all, you have to identify whether this is a case of paucibacillary or multibacillary. So first catch is, there are 2 hypopigmented patches. Now in paucibacillary, the patch number may be 1 to 5. In multibacillary, it should be more than 5. 1 thickened nerve. Now the classification has been updated. Earlier we include till 1 nerve in paucibacillary, but now remember, if there is no nerve involvement with the skin patches, less than up to 5, 1 to 5, it is pauci. But if it is more than 5 or any of the nerve involved, it is your multibacillary. So it is a case of multibacillary. Okay. So it is a case of paucibacillary. So this is out from my choice. It is a case of multibacillary leprosy, and we are giving the 12-month treatment. So how intelligently you have to choose your choices. Those who are with the A answer, it is out because it is not a possibulary. Now we are left with the three choices. Okay, so B is your correct answer. Then undergoing program is the National Leprosy Elimination Program. Now again, this is the only program which is a National Leprosy Eradication Program. It is not an elimination program. So this is also not your correct answer. So that choice with the C, it is out. So this is also not my correct answer. Okay. Single dose rifampicin to close contact of the newly detected case as a post-exposure prophylaxis. Yes, this is the correct answer. So this is your correct answer. That is option number D. And set centers is the main infrastructure of this program. So yes, this is also your correct answer. So you all are answering correctly. That is option number C. It is your correct answer. That is set center is a survey, education and the treatment center. It is the main infrastructure of the program. So we should be remembering the infrastructure like a DMC center, designated microscopy center, it is for the tuberculosis. ICTC centers, integrated counseling and the testing center, it is for your HIV. ART centers, ART plus centers, then Link ART centers, they are all related to HIV. Then we are having the vision centers or the service centers. It is from the blindness for the blindness program. So question is asked, their centers, their population coverage, and for what disease they are. So be very careful. Okay. Then coming to some of the important points about leprosy, because some updates has come up for this. So that's why I thought that we should be discussing this disease. One is the update has come in classifying the leprosy. As we had already discussed, the number of the skin lesion, if it is 1 to 5 with no nerve involvement and any of the smear should not showing the lepra bacilli, all smear should be negative. It is considered as possibulary. And if skin patches are more than 5 or one or the more nerve affected or any of the skin smear is showing the lepra bacilli, it is a case of multibacillary. Now the 3-drug regime we follow in all the 2, possy and multibacillary, and the drug is rifampicin, dapsone and clofazimine. Rifampicin is given once a month, 600 milligrams supervised. Every month we call the person and health worker is giving the medicine under supervision, and patient should not vomit out. So we will be waiting for half an hour, patient should not vomit out. Then we are giving 300 milligram once a month supervised clofazimine, and then we are handing over this pack to patient and they are taking 50 milligram oral daily as well as 100 milligram oral dapsone. 1 tablet of dapsone we are also giving on the first day under supervision along with rifampicin and clofazimine. This goes for 6 months in possibulary, 12 months for multibacillary, and we are calling our patient for follow-up yearly for 2 years in possy and yearly for 5 years in multibacillary leprosy. Then some of the important points are that ASHA is a main worker for active surveillance, and the activity is what is called as APSL. It is ASHA-based surveillance for leprosy suspects. She is trying to detect the suspected case of leprosy. Then we are having Sparsh leprosy awareness campaign. It is conducted through Gram Sabha. Sparsh कहते हैं टच करना, क्योंकि अभी भी पेरिफेरी में ये छूत की बीमारी समझी जाती है. Means this disease can transmit from skin to skin contact to another. So the leprosy patients are neglected. So we have to avoid the social stigma, and we are having the set scheme through the NGOs. That is, we are motivating that patient who had any symptom should come forward and tell to the health worker, diagnosed and should be treated. Sapna is a mascot which is adopted by Indian government for a leprosy. We are having now integration of this leprosy screening for children under the Rashtriya Bal Swasthya Karyakram as well as under the Rashtriya Kishore Swasthya Karyakram, as well as those who are coming for screening of non-communicable diseases at 30-year plus. We are also trying to look for leprosy in that. And if one person is diagnosed with leprosy in a family, we are giving the post-exposure prophylaxis with single dose rifampicin to close contact. And this was one of the question asked earlier, that who are called as close contact? Those who stayed for more than 3 months having contact of 20 hours or more per week from a newly detected leprosy case in past 1 year, they are considered as a close contact, and we are giving single dose of rifampicin, although this depends upon the age of the person. But if adult age, we consider the weight is 35 kgs or more, the dose is 600 milligram. Okay, and nowadays, if a leprosy vaccine is available in that area, we are giving along with leprosy vaccine also. Another very important are some of the indicators. Now here this I'll expect you to remember, because could be asked in the exam. One thing is, this program is a eradication program. Be very careful. Our goal is to make India free from leprosy, or the leprosy Mukt Bharat by 2027. And our targets are that we have to bring down the prevalence at the subnational or the district level less than 1 per 10,000. Annual new case detection rate should be less than 10 per 1 lakh. The grade 2 disability means we should try to detect earlier before the advanced stage. So grade 2 disability among the new detected cases at the national level should be less than 1% of all the total cases, or if we go with the actual number, should be less than 1 per 10 lakh. Disability among the new child that are less than 15 years should be 0. So we will be conducting this program, so no child should be having the disability. We should be detecting early, and there should not be any stigma related to this condition. Okay. What are the indicators for this program? The most important epidemiological indicator is annual new case detection rate. Most important operational indicator is new case with grade 2 disability. The prevalence is indirectly reflected by case load, or it is for planning of the treatment services, and incidence is reflection of effectiveness of the program and monitoring the success of control program. So these are some of the important indicators. Okay, dose for a child of 9 to 14-year-old will be definitely the lesser dose of the rifampicin, dapsone and clofazimine. This what I am talking about is 14-year plus, that is adult dose. 32-year 10-week pregnant female patient who had returned to Delhi from Manipur after her 10 days holiday vacation tour, presented to clinic with high-grade fever with chills and rigors, severe headache, on investigation diagnosis Plasmodium falciparum infection. Now, whenever the question is asked about the malaria treatment, first of all look for the species, and here the species is, it is falciparum infection. Second is, for the falciparum we have to look whether they are talking about the northeast states or other states. Patient is returning from Manipur. It means returning from northeast states. The third point is, we will be looking for whether she is a female, she is pregnant or not. Agar pregnant hai, to what is the gestational age? So she is pregnant, that is 10 weeks. So we know in falciparum first trimester the drug of choice is quinine only. In second and third trimester, based on the states, agar ye Vivex hota, then it is chloroquine. Okay, so chloroquine only, no, it is for the pregnant patient with 5X infection. Chloroquine with primaquine is contraindicated in pregnancy, so no question. So you all are answering correct, but yes, there is some confusion also about option number D. That is not the answer. So quinine only is your answer. Artemether-lumefantrine combination therapy beta, it is given if the question says not the 10 weeks. Here this 10 week means it is the first trimester. If they say the lady is coming in the 4th month or the 5th month or the 6th month, then it will be the artemether-lumefantrine combination. Okay, but here it is the 10 weeks, so it is quinine. So we should be very clear about the treatment of choice. So for the Vivex infection in all the states, it is chloroquine with primaquine, chloroquine 3 days, primaquine 14 days. Try to remember the primaquine dose, it is 0.25 milligram per kg per day for 14 days. But in pregnancy, it is only chloroquine in all the trimesters in all the states. Okay, falciparum mein in the northeast states, if it is not a pregnant patient, that artemether-lumefantrine for 3 days, and on the day 2 we are adding single dose of primaquine, just the 3 times of the Vivex dose, that is 0.75 milligram per kg the body weight. And these are the different color blister packs are there for different age group of the individual. Okay. Then in the other than northeast states, we are having artesunate, sulfadoxine, pyrimethamine. Artesunate we are giving for 3 days. Then along with this, day 1 pe we are adding the sulfadoxine pyrimethamine, and the day 2 we are adding single dose of primaquine. But if it is a pregnant patient, then in falciparum infection, quinine in the first trimester, second and third, as we had already discussed, is northeast states में artemethyl-lumefantrine, other states में artesunate, sulfadoxine pyrimethamine, but primaquine is contraindicated. Other questions are asked from this area is that for the prophylaxis. Now here it depends upon the duration of stay. If it is less than 6 weeks, doxy, more than 6 weeks, then mefloquine or chloroquine. But if patient is pregnant, then it is only chloroquine. Very important question is that for how long we have to continue after leaving the area. We have to continue for 4 weeks after leaving that area of malaria prone. What are the indicators? Very important question is asked is that API is an indicator of which program? It is for the malaria. It is annual parasite incidence, suggestive of active malaria transmission. Recent malaria transmission is infant parasite rate. Then we can be having annual blood examination or the rate or slide positivity rate. Okay. So this is again very important flashcard where I try to summarize all the indicators of malaria program in one page. This will help you for revision. Now some more points are about the program, that our goal is elimination of the disease by 2030. And as we had already discussed, the strategy should be test, treat and track. We have to track from which area the patient is coming, because we have to go for mosquito population, and we are having vector control. And यहाँ पे important point है कि female anopheles after bite, where she is resting inside house. So we are having indoor residual spray. Indoor residual spray for killing those female anopheles who had taken blood meal. Some important questions had been asked repeatedly. Which is the worker for active malaria surveillance? We all know it is multi-purpose worker male. Multi-purpose worker male, it is for malaria surveillance. Best test for malaria diagnosis. Best test for malaria diagnosis is peripheral blood smear examination. While the best test for filariasis, be careful, it is a membrane filtration test. It is not the peripheral blood smear. And यहाँ पे हम दो smear बनाते हैं for malaria, thick and the thin smear. And for filariasis, we make only single thickest smear. So malaria program is a very important national program. Many questions are asked from this area. We should be confident, but we should not be overconfident. Remember this point. So we have to practice like कि कोई भी मैच हम नहीं जीते हैं तो जी जान लगा देना है कि नई नई ट्रिक्स सीखना है, किस तरह से हम अपना मैच जीत सकते हैं. So you have to make the practice or do practice like you had never won, and you have to act on 26th of July 2025 in the examination hall with such a great confidence that you had never lost in any of your tests. You had always scored marks around 70-80% in the test, and you have to perform best on your exam, on that particular day. Just a minute. Now, what is correct about National Tuberculosis Elimination Program? National Tuberculosis Elimination Program. Again, this is a very, very important program. Investigation of the choice in a patient of HIV is CB NAT. Yes, this is a true statement. Investigation of the choice in a patient of HIV is CB NAT. Under Nishchay Poshan Yojana, 1,000 rupees one-time payment. 1,000 rupees, a one-time payment we are having. Okay. So, here what is that it is not your Nishchay. So, under Nishchay portion yojana, so there are the two wrong words in this is, first is it is not a Nishchay, it should be a Nikshay portion. Second is we are not having 1,000 rupees one time, we are having 1,000 rupees per month. Okay. Pre-XDR patients, they are resistant to INH rifampicin only? No. They are resistant to the fluoroquinolones also. Okay. So, this is also false statement. The BPAL regime is for treatment of MDR cases. Yes, this is the true statement. We are having now the BPAL regime. The important infrastructure of the program is DMC centers, which is covering population of 50,000 in the plain area. No, it is covering the population of 1 lakh in the plain area. In the hilly and the tribal area, it is covering 50,000. So, this is also your false statement. So, which are correct? So, only the two statements are correct, that is option number A and option number D. So, A, it is in all the choices. Now, those where we are having the B, it is out of the scene because B is a false statement. Then we are having the D is the correct answer. So, answer to this is, that is option number D or the 4. So, yes beta, A and D is correct. So, option number 4, it is the correct answer for this is where A and D is the correct answer. So, this is again a very, very important program. So, we should be learning some important point about this program, that is how you will be categorizing the patients, because commonly the question is asked that those who are showing the sensitivity to rifampicin, they are the drug sensitive tuberculosis patients. So, sensitive to rifampicin, that is a main important drug, as well as to INH. Okay. But if they are showing resistance to the INH and the rifampicin, they are called as MDR cases or the multi-drug resistant cases. If they are resistant to the INH rifampicin as well as any of the fluoroquinolones, they are the pre-XDR cases. But if they are resistant to the INH rifampicin, fluoroquinolones and any of the category A drug as a bedaquiline and linezolid, they are the XDR cases. Then how we are going to treat drug sensitive cases? It is the 6-month regime, that is 2 plus 4. It means the 2 months of the intensive therapy, every dose is given by health worker, and the continuation phase, that is the patient is taking on their own. So, 2 months of HRZD and 4 months of HRE, so total 6 month duration is there. Now, MDR or the rifampicin resistant cases may, earlier we are having the shorter or the longer course which is lasting for either the 9 to 11 months or even up to 22-24 months, but now at least remember the BPAL regime what we are giving for MDR cases, it is for 6 months, or BPAL regime what we are having in pre-XDR cases. Okay. So, BPAL regime what we are having for 6 months, remember this is the latest update for MDR cases we are giving. Then there are some more important points is that if a patient is having both HIV and tuberculosis together, so point number 1, which is the test for the diagnosis we are having as a preference is CB-NAT, and second is if both the things are diagnosed together, first we have to start ATT for 2 weeks. Okay, and then after 2 weeks we have to add ART to avoid the immune reaction, that is what is called as IRIS. Another is if a patient is pregnant and having tuberculosis, it depends upon what type of the TB and which trimester of the pregnancy. If she is having drug sensitive TB, in all the trimester the drug is safe, but if it is a MDR or above that, then that some drugs are not safe still in the first trimester or in the pregnancy. So, our main focus is that if we can do MTP, means if a pregnancy is less than 24 weeks, then do MTP first, save the life of the patient, and then start the BPAL regime. But if MTP is not possible, if the pregnancy is beyond 24 weeks, a patient is not willing to undergo abortion, then we have to give the shorter oral a short MDR or long oral MDR with modifications, okay? And we are not giving the amikacin or mecacin injections. We have to replace them with the PAS, para-aminosalicylic acid, till she delivers, and after that we can start the actual regime. Then we are having some incentive given to ASHA workers, okay? So, or any of the DOTS provider, the health worker who is monitoring these patients. So, completion of the drug sensitive TB, we are giving 1,000 rupees, and completion of MDR or the XDR TB, the total 5,000 rupees we are giving in the 2 installments. So, यहाँ पे be very careful. The installments are opposite to the Matru Vandana. Matru Vandana में भी total 5,000 था, but first installment was 3,000 and the second after delivery was 2,000. यहाँ पे उल्टा है. So, first we are giving the 2,000 rupees at the end of the intensive phase, and the remaining 3,000 rupees we are giving at the end of the continuation phase. जैसे इसको कैसे याद रखना है कि whenever you are having some construction work going on in our house and we had one contractor, so we don't pay whole amount. पूरा पैसा नहीं दे देते हैं, रोक के रखते हैं, थोड़ा सा अमाउंट देते हैं, ठीक है? काम पूरा होने पे देंगे. अगर आपने ज्यादा अमाउंट दे दिया तो काम छोड़ के चला जाएगा. So 2,000 rupees at the end of the intensive phase and the remaining 3,000 at the end of the continuous phase. Then we are giving incentive of 500 rupees is that if she is able to detect any suspected case of the tuberculosis and referring to the higher center for the confirmation of the diagnosis, and if the diagnosis is confirmed, then she is given a 500 rupees as an incentive. Now, some more points are important about TB. One is NICSHE. It is a tuberculosis software. Don't confuse with the NICSHE. It is a urine pregnancy test kit, and NICUST. It is the software for leprosy. Then we are having DOTS 99. It is for the drug adherence. When patient is taking the medicine, on the wrapper there is a toll-free number, so they have to give missed call. So at least it is registered on the NICSHE portal that patient has taken medicine. Otherwise, they will get the reminder. Then we are having NICSHE Poshan Yojana. NICSHE Poshan Yojana. It is 1,000 rupees per month till end of the therapy for all categories. Okay. Then we are having NICSHE Mitra. It is adoption of TB patients for their proper care. JEET initiative, it is a joint efforts to eliminate tuberculosis. It is a joint effort between a public and private practitioners. Then we are having MERM, that is medicine event reminder monitors. It is a box, digital box. If you are not opening that box till a desired time, then it will be giving you an alarm that you have to open the box, and once you take out the strip, automatically it is registered on the NICSHE portal. Then infrastructure we are having is DMC centers, designated microscopy centers. So again, this is a very important flashcard where I try to summarize the infrastructure of 4 important national programs, that is tuberculosis, then we are having HIV and blindness program and leprosy program with their population coverage, and very commonly asked from us in the examination. Patience is a very important key of success. एक दिन में पैलेसेस नहीं बनते हैं, लेकिन एक दर्जन जरूर बनते हैं, ठीक है? So success requires a daily action, and definitely a day will come when we all get success in life. And first step of our success is to get success in our upcoming examination. So have patience, just go on doing work assigned on our part, and definitely a day will come when we all get success. All are correct about National AIDS Control Program. So another very, very important program, that is National AIDS Control Program. So all are correct about. So what we have to find out? We have to find out the incorrect option. So all are correct about except long distance truck drivers are high risk population. This is a true statement. They are considered as a high risk population. Investigation of the choice in 4-week-old baby to check for mother to child transmission to check for mother to child transmission is RT-PCR. Yes, because baby is in window period, so we are going for RT-PCR. Okay, and window period is 3 months. After 3 months, we can go for ELISA in the baby, but baby is 4 weeks old, so we have to go for RT-PCR. Now, ART treatment started as soon as possible after the diagnosis, irrespective of CD4 count. It is also a true statement. Known case of HIV positive mother taking ART throughout the pregnancy duration. Then newborn prophylaxis is with the 6 weeks nevirapine only even in breastfeeding mother. If mother is taking ART throughout the pregnancy, mother is a low risk, very low viral load. Then we are giving prophylaxis for 6 weeks only with nevirapine irrespective of the breastfeeding. So this is also the true statement. Now listen carefully. Intentionally, I had kept all these choices for a very important take-home message. अब आपको एक बार में देखने में क्या लग रहा है कि चारों ऑप्शन करेक्ट है, देन व्हाट शुड बी माय आंसर? ऐसा तो नहीं मैडम कोई क्वेश्चन गलत बना दिया उन्होंने, भूल गई है कोई ऑप्शन, ऐसे फॉल्स स्टेटमेंट रखना. नाउ इफ यू go deeper in these choices, long distance truck drivers and single male migrant labor, they are considered as bridge population. So if we go further in that which are considered as a high risk population, the 4 are very important high risk population: sex workers, transgenders, man having the sex with man, and IV drug users. They are actually the high risk. Then what is a bridge population? Means from the high risk they are taking the infection and then they are spreading to the community. These are the long distance truck drivers or the single male migrant labor. So if we have to choose which is least correct, is the long distance truck drivers, because the best answer is that they are the bridge population. If the bridge population is not in that, then you can go with that they could be the high risk population. But as all the 3 are the absolutely correct statement, so this is a weaker statement going towards an incorrect statement. So answer for this is option number A. So very important take home message is that in the exam, you have to choose the best possible answer from the given choices. Sometimes it may not be a correct answer, but it is the best possible answer for your given for the question from the given choices, and this is the important take home message from this question. As this program is a very important program, so important points we have to remember that once we diagnose a patient, now we have to start ART immediately irrespective of the CD4 count. This is the first question. What drugs we are giving? Now we are having the fixed dose combination, but the single tablet patient has to take because lifelong it has to be taken for all the patients who are living with HIV, that is PLHIV, and the drug which is being given is called as TLD, tenofovir, lamivudine, and dolutegravir we are giving as first line therapy. Now what is about the post-exposure prophylaxis? Here the 3 points we have to remember. Number 1 is when we have to start as soon as possible within 72 hours, but best is if you can start within 2 hours, to be given for 28 days, but confirmation whether you had an infection or not is only after the 3 months by ELISA, not in between, because sometimes we may be getting a false results with if you are applying an RT-PCR in between. So give for 28 days and sound sleep आपको सिर्फ 3 महीने के बाद आएगी when your ELISA is negative. Very important section from where the question is asked is if a mother is an HIV positive, how you are going to protect the baby, because untreated mothers में mother to baby transmission is 30% in pregnancy, remember, and additional 12 to 14% in breastfeeding mothers. But if you are giving the drugs to mother throughout the pregnancy as well as giving a newborn prophylaxis, then risk of transmission is less than 1%, even if she is breastfeeding the baby. And this is our goal, that HIV positive parents should deliver an HIV negative baby. So here the question is that if a mother is a known case of HIV, taking an ART should be continued even in the first trimester. But if she doesn't know the status and she has been diagnosed in the routine checkup in pregnancy, to be started as soon as possible on the diagnosis, to be continued throughout the pregnancy and breastfeeding also. And this is the secondary level prevention because we are treating the mother. But for the baby, because the time of transmission is at the time of delivery, so we are protecting, and that's why it is called as newborn prophylaxis. And we have to start within 72 hours, the best is within the 2 hours, and what to be given depending upon the mother treatment. If a mother has taken for more than 4 weeks sufficient duration, mother is a low risk, then we are giving only the single drug, nevirapine, 6 weeks to the baby irrespective of the breastfeed. Baby is on breastfeed or on the top feed. But if a mother has not taken any ART or has taken for less than 4 weeks, then mother is considered as a high risk. 2 drugs we are giving to the baby, nevirapine and the zidovudine. Now here, if a baby is on the top feed, then only give for the 6 weeks. But if a baby is on the breastfeed, we have to give a minimum for 12 weeks. We can be extending till 6 months also depending upon follow-up. Then high-risk cases we had already talked about. Special infrastructures we are having, ICTC centers, straightforward question. It is related to which program? It is related to AIDS control program. Integrated counseling and testing centers from the district hospital onwards. Same time, if a patient is coming to ICTC centers, then we are doing the counseling and treating our patients, and if they are positive, we are sending to the ART centers which are giving the first line therapy. After taking the medicine, patient is coming home, and for the follow-up they are going to the link ART centers, and if resistant, then they are going to the ART plus centers where we are giving them second line ART therapy. Then what are the goals of our program is that we have to reduce the new HIV infection and the AIDS related death by 80%. We have to eliminate the vertical transmission of HIV from the mother to baby as we are doing. Then eliminate the stigma which is related to the disease and promote the universal access to quality STD services. And our target is 95, 95, 95, 95, 95, 95, while in the tuberculosis it is 90, 90, 90. Now, some important centers has been designed. We are having Sampoorn Suraksha Kendra, single center. Sampoorn matlab sari facilities, all the total facilities for the protection against the STDs will be available at one center. So here our strategy will be, we are motivating them for prevention of the disease by use of barrier methods. Then suspected patients are tested, and if they are found to be positive, we are treating them. Okay, one-stop centers we are having. IST clinics. Now we are integrating the HIV services with other clinics also. That is integration of syphilis, HIV, tuberculosis and hepatitis B and C, because these are the diseases which are transmitted through the sexual route, and the tuberculosis is an opportunistic infection commonly seen in HIV patients. Then we are having the decentralization of the services, that is DISHA. Okay. Earlier the services were available in the higher centers like medical colleges, but now we had all these facilities available at the district hospital level. So we are having the district integrated strategy for HIV and AIDS, that is what is called as DISHA. Okay. Now another update has come up as earlier we were having in the syndromic approach of management in Suraksha clinics. The 7 kits were different symptomatic treatment of sexually transmitted conditions, but now we are having 8 kits are there, and this kit number 8, that is brown kit, has been added. It is for anorectal discharge or symptoms ke liye hai. Okay, so now we are not having the 7 kits here, we are having 8 kits in that. You will agree with me that in this journey, huge sacrifice has been made by your parents. तो कई बार आपको लगता होगा यार क्या करना है, मेडिकल किताबें इतनी मोटी मोटी किताबें हैं, 19 वर्कबुक्स है, मेरे को ये इतना कंटेंट है, मैं क्या करूं, कैसे पढूं, ये किताब मुझे पसंद नहीं आ रही है, मुझे तो नॉवेल पढ़ना है, मुझे तो मूवी देखना है। लेकिन फिर दिल कहेगा कोई बात नहीं बेटा, पढ़ ले, क्योंकि सुना है कि माँ बाप का सपना तो इन किताबों से ही पूरा होना है। सो ऑलवेज think sacrifice of your parents in your thoughts, and you have to study for yourself, of course, but for your parents sacrifice also, because ultimately you have to show them a paper where PASS is written, and I think that moment more than you, they will be happy. A 6-month-old child reported to sub-center with complaint of fever and breathlessness. On examination by multipurpose worker male, it was reported that the respiratory rate is 55 per minute and presence of chest indrawing. Correct statement as per MNCI program. Now here, this type of the question is asked, you have to look for what is the age of the baby. Age of the baby is 6 months because respiratory rate changes with the age. Up till 2 months, it should be 60 or above to call as pneumonia. 2 months to 12 months, it should be 50 and above to call as pneumonia. And 12 months above, it should be 40 or more. So baby is 6 months and respiratory rate is 55 per minute. So baby is having pneumonia. Now, we have to differentiate whether it's a pneumonia or the severe pneumonia, then look for the accessory symptoms. Now, earlier, we were having the chest indrawing and all included in the severe pneumonia, but now it is changed. If a baby is not HIV, even more than 2 months with presence of the accessory muscle involvement will be a pneumonia category. And pneumonia category is coming in the yellow category. Okay. So, home management green category, no. Antibiotic follow-up yellow category, yes, because yellow category, we have to give the antibiotic and do the follow-up. And antibiotic and immediate referral, beta, this was the old guideline where we were immediately referring. But another the catch is that it was not given the color as red. In IMNCI program, it is green color, yellow color and the pink color has been given. So, it is the severe pneumonia, okay, not the plain pneumonia or severe or very severe ke liye this is included. If they say that this baby is HIV positive, then the answer will be your option number D. But here they didn't mention about the HIV, so the answer for this is antibiotic follow-up and this is your yellow category. So this is the classification of the pneumonia. So first of all, you have to look for what? You have to look for the respiratory rate and then you have to look for accessory muscle involvement. If it is present and the baby is more than 2 months without HIV, treat as pneumonia. But if a small baby or any older baby of 2 months above with HIV is a severe or very severe pneumonia, okay? Always, always, always believe on yourself. You are working so hard, so believe on yourself. It will remove 50% of your anxiety, I am very sure. Like होता है ना, आपने सुना होगा कि पेरेंट्स बच्चों को एक पर्टिकुलर डॉक्टर के पास ले जाते हैं, अरे उस डॉक्टर की दवाई अच्छी है, उसकी लगती है, बच्चों को छोड़ो, खुद भी चलेंगे, अरे वो डॉक्टर अच्छा है, उसकी दवाई अच्छी है. It means they had confidence in that doctor and once they had a confidence, 50% of their problem is automatically treated. And this is what we called as psychotherapy or teletherapy what we had, and it is a proven fact is this. If you had a self-belief, then many of the patients, they are treated on their own. So same thing is that you have to believe on yourself that yes, you are working hard to that an extent that is more than enough to not only clear the exam, but to get a good score in the examination, and definitely you will get it. Now coming to our second last question, 35-year male who is on ATT and ART treatment for past 6 months daily, taking the treatment and daily going for the morning walk. One day while walking, street dog jumped on him, but he had only the minor scratch on his right hand without any blood. What to do? Now here, there are the two catch in this question. Catch number one is, patient is HIV, who is taking ART and opportunistic infection, also having ATT. Second catch is having the minor scratch on his right hand without the blood. So what is the grade of this is? It is a grade 2. We know that in the general category, if it is a grade 2, like we had remembered, अगर grade 1 है, only the lick on the intestine, 1 action, only local cleaning. Grade 2, 2 action, means any scratch or nibbling without the blood, local cleaning and vaccine. And the grade 3, multiple lacerated wound or any wound with the bleeding or a splash on your mucosa, 3 actions, vaccine, immunoglobulin and local care. But in HIV, even in the grade 2, you have to treat like as a grade 3. This is the catch. Okay, you have to treat like as a grade 3. So just assurance, no. Just wash and apply the local povidone-iodine, no. Just wash an area and apply the local povidone-iodine with the full course of anti-rabies. This is if a patient is not HIV, then it is a grade 2, 2 actions. So it is again not, because the catch is the patient is HIV. So wash the area and apply the local povidone-iodine and then the full course of anti-rabies vaccine plus immunoglobulin, because immunity is poor. So consider the grade 2 as a grade 3 bite if a patient is HIV. This is only the catch for this question. And here the correct answer is not the option C, it is option D. So we have to categorize the wounds, and as we had discussed, if the patient is having the any immunocompromised disease like HIV hai or on the steroids treatment hai or any of a immunocompromised condition hai, then treat the grade 2 as a grade 3, means we have to have a 3 action, local care, vaccine and immunoglobulins. Okay, so we should be knowing all the points about local care, means we have to clean the wound for 15 minutes or more with typical running water, पूरा नल खोल के running water से we have to clean. Then we have to, अगर grade 3 bite है तो local आपको immunoglobulin inject करना है. It is not given parenterally, it is given locally at the wound site. And dose to be important, that human immunoglobulin use कर रहे हो तो 20 international unit per kg of the body weight, and animal immunoglobulin है, then we have to 40 international unit per kg of the body weight. No suturing should be done at least for minimum 24 hours, and schedule is again very very important. The pre-exposure prophylaxis, so always read the question carefully whether they are asking pre-exposure or the post-exposure. अगर post-exposure है, so any previous history of receiving vaccine in past. So pre-exposure prophylaxis, the schedule is 0, 7, 21 or 28. Then post-exposure prophylaxis, if it is a non-vaccinated individual, intramuscular schedule is 0, 3, 7, 14, 28, and intradermal is 2, 2, 2, 0, 2. It means that 2 sites you are giving on the days, same as a 0, 3, 7, 14 and 28. So day 14 ko we are not calling this our patient. So 4 doses we are giving. And if you have to choose between these two, so always remember the intradermal is preferred over intramuscular because it is having good antibody production, and the higher vaccine doses we can be giving by the intramuscular route as a Zarab regime, that is 20101. Here instead of the 1 ampule of the injection on the day 0, we are giving the 2 injections. So here the number are representing the number of the injection ampules. And if it is a post-exposure prophylaxis में, in the person who had received the vaccine in the past, if within 3 months में है, so only the local care, even for a grade 3 bite. If it is between 3 months to the 2 years, we have to give the booster, maybe intramuscular or intradermal, and on the day 0 and the day 3. Here remember, it is 0, it has no connection with the dog bite. It is when you are starting the vaccination, okay? So it is day 0 on the day 3, and obviously the intradermal is preferred over the intramuscular, and if it is beyond 2 years back, and then we have to give the full schedule. So this is all about our rabies prophylaxis. Whatever has happened in the past, whatever your up and downs, don't focus about that. Don't think about that. Ultimately, at this moment, what you have to focus is your computer screen on 26th of July, that you are just answering your questions correctly, and 15-20 days later you are just watching your result on the computer screen and a PASS word is written in front of your roll number. So you have to think only about the ending, that what should be my end. And the last question for this session is that how to protect 32 weeks pregnant patient in family from 6-year-old child with rubella infection. 6-year-old child with rubella infection. Now we know that rubella is an infection which is having a possibility of congenital malformations, provided. This is the trap in this question. I'll wait for the answer and then I'll answer this. First of all, I'll wait for your reply. Then I will just disclose the trap of this question. I'm waiting for your answer. Okay? Give rubella immunoglobulin only if the IgG antibodies are negative. IgG antibodies are negative, it means the patient is at risk. So we can give immunoglobulin because vaccine, it is a live vaccine, we cannot give. If IgG antibodies, irrespective of IgG antibodies, no. If it is positive, then there is no sense of giving the injection, this immunoglobulin. If it is positive, then there is no sense of giving. So now there is only the tie between the option number A and option number D. So Venkat and Kuma and Sandesh, I think you understood the trap, and the trap is that how much is the pregnant duration? 32 weeks. We know the congenital malformations are till 20 weeks. If infection is happening before 20 weeks of pregnancy, then there is a risk of congenital malformation. Then we are giving immunoglobulins, but if it is after 20 weeks, then there is no risk of congenital malformations. Okay? So, no immunoglobulin is needed irrespective of the antibody status. Maybe rubella IgG antibodies are negative, because positive mein to zarurat hi nahi hai. Even if it is negative, then there is no need because she is 32 weeks pregnant patient. Yes, you got the catch. So post-exposure prophylaxis mein, first of all, we have to look for the IgG antibodies. If it is positive, then no action is required. Okay. If it is negative, then look for pregnancy. If there is no pregnancy, in that case also, no action will be required. Okay. And if it is positive pregnancy, and if the duration is less than 20 weeks, then we have to give rubella immunoglobulins. But if a pregnancy is more than 20 weeks, in that case also no action will be required. And in this way, how we are protecting our pregnant patient. Now, very common situation is coming that recently married couple, they are coming to clinic and they say that we are planning for pregnancy, so we have to do the screening for IgG rubella, and if the IgG rubella, if it is present, we can say okay, you are safe and you can go for pregnancy. But if it is negative, we say wait, and wait करने के बाद क्या देंगे? We are giving them the rubella vaccine. And a very important advice at this point you have to give, that you have to avoid pregnancy for 1 month. We advise them to use contraceptive for 1 month because iatrogenically you are creating infection. Okay, so this is all. Yes, beta, we had done with our 25 clinical questions, but along with that we had covered more than 100 questions, I think. Then the last, I'll take 2-3 more minutes before we can wind up our session. That from today onwards, I don't want any message from any one of you कि मैडम अब मुझसे नहीं हो सकता. होगा, क्यों नहीं हो सकता? बिकॉज जो जीत है ना वो दिमाग में आती है, ठीक है? विन इन योर माइंड एंड यू विल डेफिनेटली विन इन द रियलिटी। जो कहते हैं ना, मन के हारे हार है और मन के जीते जीत। अगर आप मन से हार गए, हार जाओगे, लेकिन अगर मन में आप जीत रहे हो, सो डेफिनेटली यू आर गोइंग टू विन। सो be confident, be positive, and just a golden rule in this journey of the last 32 days. No comparison with others. ठीक है, ग्रुप स्टडी कर रहे हो, नो कंपैरिजन ऑफ द मार्क्स विद अदर्स, डू नॉट रीड एनीथिंग न्यू। इतना कंटेंट है आपके पास में, इट इज मोर देन एनफ इफ यू कैन वाइंड अप एंड रिवाइज। सो FOMO वर्ड शुड बी आउट कि आई एम नॉट मिसिंग एनीथिंग। No influence of the mock test results, just learn from your mistakes. Adequate physical and the mental rest is very, very important. Do not expect to revise everything in this journey. Just try to revise the high-yield topics and have a quick revision of the things, because already the concept is in your mind. Good hygiene, hygienic food you have to take to maintain your health. Learn from your mistakes in the previous test. Try to improve them. And be smart, because world is only waiting for your result. Never give up hope till the last question is submitted in your exam in the second session, because that last question can change your scenario. And only have to focus on your first key, that is the key of your hard work. Don't bother about the second key of your luck. If you are putting your first key, definitely your bank locker will be open, and already a certificate is made by your name, already kept in National Board locker. So I think after this exhaustive 3-hour session, so you can say कि today evening is a perfect evening for me, where I had tried to revise the high-yield topics of PSM. You should be feeling very happy at this moment, and be stress-free till the exam, and we all are waiting for the moment when you will be just sending the picture with this medal of pass certificate with you. So thank you very much. Love you guys. So I think I had tried to cover up maximum high-yield topics from the subject in a limited time. I had tried to solve the queries, try to answer all your questions also. Still, if you had a doubt, you can just message me, and this PDF will be available in the description box along with this video. Okay? So love you guys. All the best. And thank you all for patient hearing. Although we gone a session for 3 hours, but at least minimum 2.5 hour concentration is required from us in the examination hall. So I'll not take much of your time, beta. So we are closing the session. Okay? So all the best. God bless you. Bye-bye. Good night.